How are you today, doctor? Well? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for doctors today.
Speculation has been about exactly what the president will announce. Will we descend down to alert level 2, and with it, what are the stipulations, all of that?
Because of you,
I fear less.
I hurt less.
because of you, I'm back at work.
I'm playing with my children.
And our days can begin to feel normal again.
Because of you,
I know the true meaning of leadership,
Of courage.
of love.
And I see what it means
to truly sacrifice.
all because of you.
To all our frontline healthcare workers,
Siyabonga.
Dankie.
Enkosi.
Thank you.
How are you today, Doctor? Well? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have Discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra Discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more Discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for Doctors today. With over 750 patients being treated at any one time, we are reimagining healthcare to bring you South Africa's largest virtual hospital.
It was advisable for me to be hospitalized at home.
I was so scared to go to hospital.
I mean, the comfort of being at home, of course, is first and foremost.
At home, it worked wonders.
Discovery Health Hospital at home. Connect to quality hospital-level care in the comfort of your home through cutting-edge digital healthcare technology.
This little device that they attach on my chest.
It's just brilliant. It was comfortable, it was easy.
Rest assured at home with round-the-clock remote monitoring.
I would be woken up at night because my temperature was spiking.
A clinical care team is on hand 24/7 to check your vitals in real time.
Like they would also call me on a daily basis around.
I found the experience very good, professional, the attention to detail.
With a focus on recovery, our supportive services offer medicine and food delivered conveniently to your door.
I felt like I was in very good care. They know exactly what they're basically doing.
Connect with your doctors daily via virtual ward rounds.
The platform has been extremely useful to engage with our patients.
They would always call me in the morning to find out how am I, what.
Your personalized care team is our priority to meet all your medical needs.
Even having blood drawn, that was done from the comfort of my bed.
Because I felt like I was getting Rolls-Royce treatment, and I said...
And when you need hospital-level interventions, we'll bring them to you. Healthcare professionals are on hand for home visits for your complete peace of mind.
Absolutely, first world-class care.
Connected, convenient, complete care for your hospital stay at home. Hospital at Home. Discovery Health. Reimagining healthcare. How are you today, Doctor? Well? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for doctors today.
Speculation has been about exactly what the president will announce. Will we descend down to alert level 2, and with it, what are the stipulations, all of that?
Because of you.
I fear less.
I hurt less.
Because of you, I'm back at work.
I'm playing with my children.
And our days can begin to feel normal again.
Because of you,
I know the true meaning of leadership.
Of courage.
Of love.
And I see what it means.
To truly sacrifice.
all because of you.
To all our frontline healthcare workers,
Siyabonga.
Dankie.
Enkosi. Thank you.
How are you today, Doctor? Well? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have Discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra Discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more Discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for Doctors today. With over 750 patients being treated at any one time, we are reimagining healthcare to bring you South Africa's largest virtual hospital.
It was advisable for me to be hospitalized at home.
So I was so scared to go to hospital.
I mean, the comfort of being at home, of course, is first and foremost.
At home, it worked wonders.
Discovery Health Hospital at home. Connect to quality hospital-level care in the comfort of your home through cutting-edge digital healthcare technology.
This little device that they attach on my chest.
It's just brilliant. It was comfortable. It was easy.
Rest assured at home with round-the-clock remote monitoring.
I would be woken up at night because my temperature was spiking.
A clinical care team is on hand 24/7 to check your vitals in real time.
Like they would also call me on a daily basis around.
I found the experience very good, professional, the attention to detail.
With a focus on recovery, our supportive services offer medicine and food delivered conveniently to your door.
I felt like I was in very good care. They know exactly what they're basically doing.
Connect with your doctors daily via virtual ward rounds.
The platform has been extremely useful to engage with our patients.
They would always call me in the morning to find out how am I, what.
Your personalized care team is our priority to meet all your medical needs.
Even having blood drawn, that was done from the comfort of my bed.
Because I felt like I was getting Rolls-Royce treatment, and I said,
and when you need hospital-level interventions, we'll bring them to you. Healthcare professionals are on hand for home visits for your complete peace of mind.
Absolutely first world-class care.
Connected, convenient, complete care for your hospital stay at home. Hospital at Home. Discovery Health. Reimagining healthcare. How are you today, doctor? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have Discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra Discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more Discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for doctors today.
Speculation has been about exactly what the president will announce. Will we descend down to alert level 2, and with it, what are the stipulations, all of that?
Because of you.
I fear less.
I hurt less.
Because of you, I'm back at work.
I'm playing with my children.
And our days can begin to feel normal again.
Because of you,
I know the true meaning of leadership.
Of courage.
Of love.
And I see what it means
to truly sacrifice.
All because of you.
To all our frontline healthcare workers,
Siyabonga.
Thank you.
Enkosi. Thank you.
How are you today, doctor? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for Doctors today. With over 750 patients being treated at any one time, we are reimagining healthcare to bring you South Africa's largest virtual hospital.
It was advisable for me to be hospitalized at home.
So I was so scared to go to hospital.
I mean, the comfort of being at home, of course, is first and foremost.
At home, it worked wonders.
Discovery Health Hospital at home. Connect to quality hospital-level care in the comfort of your home through cutting-edge digital healthcare technology.
This little device that they attach on my chest.
It's just brilliant. It was comfortable, it was easy.
Rest assured at home with round-the-clock remote monitoring.
I would be woken up at night because my temperature was spiking.
A clinical care team is on hand 24/7 to check your vitals in real time.
Like they would also call me on a daily basis around.
I found the experience very good, professional, the attention to detail.
With a focus on recovery, our supportive services offer medicine and food delivered conveniently to your door.
I felt like I was in very good care. They know exactly what they're basically doing.
Connect with your doctors daily via virtual ward rounds.
The platform has been extremely useful to engage with our patients.
They would always call me in the morning to find out how am I, what.
Your personalized care team is our priority to meet all your medical needs.
Even having bloods drawn, that was done from the comfort of my bed.
Because I felt like I was getting Rolls-Royce treatment, and I said,
and when you need hospital-level interventions, we'll bring them to you. Healthcare professionals are on hand for home visits for your complete peace of mind.
Absolutely first world-class care.
Connected, convenient, complete care for your hospital stay at home. Hospital at Home. Discovery Health. Reimagining healthcare.
Good morning, everybody. We're starting station 3. I'm handing over to Dr. Basu N Tlhapo, the CEO of SAMA.
Thank you, Renier. Esteemed colleagues, good morning. Welcome to day 3 of the summer conference. This is our final day. We are grateful to you for having stayed with us over the 2 weekends of this engagement. As a recap, last weekend, Summer introduced the conference during session 1. It was myself, the chairperson of the association, Dr. Mzugwa, and the president of Summer, Prof Chawuke, sharing our thoughts about the essence of the conference. Session 2 was on maternal and child health, including our ethical expert taking us through the POPI Act. The keynote address was delivered by Prof Glenda Gray, who brought to us the coalface of the COVID-19 research response, both locally and globally. Session 6 on day 2 was on internal medicine, then followed by positive ways forward for healthcare post the pandemic. And the last session was on COVID impact on surgery. Today, we are focusing on population and preventative health for session 7, with the final session on updates on occupational health. The caliber of the presentations made me proud to be associated with SAMA as an organization. I'm grateful to the key stakeholders that have done and shown the light on healthcare issues that we are still facing beyond the pandemic. The pandemic is not yet over, and we are still grappling with this new normal. However, I am encouraged that the lessons that we are sharing with you will help us fight whatever outbreak is thrown at us in the future. Once again, thank you for joining us, and let us make this day a success as all the other sessions were. I will now hand over to Drs. Maweya and Bagwadin, who will be co-facilitating the session on population and preventative health. Dr. Maweya and Dr. Bagwadin, over to you.
Thanks so much, CEO Dr. Vusi. And then we are looking forward to good presentations from our esteemed presenters. We hope that they've actually prepared very well. Thanks for that warm welcome. And then I'll hand over to Dr. Bagwandan.
Chantal. Good morning, everybody.
Oh, Chantal, it's easier.
It's so good to be here today. I would just like to perhaps take a few minutes to tell you a little bit about SAPA, the South African Public and Preventive Health Medicine Association. So we've come together as public health medicine physicians to, I think, maybe mainstream our profession. We are there, just not often in the spotlight. And I think, you know, it's with issues like the pandemic that things come to the fore, that we realize the aspects of public health medicine and the ideas around population health medicine as well. Dr. Ueckermann, thank you very much for stepping in for Dr. Prof Ueckermann, forgive me. Thank you very much for stepping in for Dr. Abdullah. And now as a physician, you're going to take us through what happens post-COVID. Over to you.
Thank you very much. Sorry, Dr. Maweya, it seems you're muted.
Yeah, maybe before she starts, let me, Dr. Shange Lindy, she has got some engagement today. So whoever wants to pose the question after her presentation, it will be welcomed if it can be, we will take those questions and then she will answer them when we distribute the conference clips at the end of the conference itself. She won't be able to sit in, present, and also answer the questions. That's what I wanted to take forward before we start. Thanks very much.
Thank you. Let me just get my screen shared. I hope that you can all see that.
We can see it. Maybe
excellent. There we go. All right. So thanks everyone for the opportunity to speak to you. I've been tasked with the topic of prevention of COVID-19 associated morbidity and mortality. So just as a quick background, I am associated with the University of Pretoria and Steve Biko Academic Hospital. I am a physician intensivist, so I have been on the front line of the pandemic and really through the various stages navigated that, and I suppose that is why I'm chatting to you about that today. What you see in front of you now is our Professor Anton Stolz's COVID ward. So I just want to take 2 minutes as a background to tell you a little bit about our story, because I think in terms of a public health response, this is really one of the success stories. Basically, at the start of the pandemic, Professor Anton Stolz, who of course was taken from us too soon, was keenly and actively involved in preparing for the pandemic to come. And at that stage, we decided that between us and our sister hospital, Tshwane District Hospital, we were going to actually create a separate COVID area. This building was tasked to be our so-called COVID hospital. In fact, we completely underestimated the pandemic, and this became only our COVID ICU. But certainly this is where many hours were spent. I think many tears from my team were shed, and certainly many lives were saved. All right, so if we look at, I've actually split it into the two, mortality and morbidity associated with COVID-19 infection. I think if we consider mortality, we have to think, of course, of the direct mortality of the pandemic, and there's no doubt that this has been a global crisis. But I think we also have to consider the collateral damage that has been associated with COVID-19, and important lessons to take from that as we go into the future in terms of the rest of healthcare and how that was affected by the pandemic. And I'm sure everybody on this Congress can think of some examples on hand of where COVID had caused collateral damage. But let's look at COVID itself, and we know that we now have, in excess of 5 million deaths worldwide attributable to COVID-19. And 2021, after we had our largest waves, and certainly our third wave in South Africa was associated with massive mortality. There's what you see now is a forest plot really of the various studies pooled. And you can see that, of course, it varied between different areas and different times. This was a pandemic we were learning a lot as we were going, and through the various waves, we managed to apply better and better knowledge and skills and hopefully save more lives. But no matter where you look, there are very few studies that had small numbers that had very low mortality. But overall, we're looking at a mortality around 41.6% of those who were admitted with severe COVID. And severe COVID then spans really people who needed high level of oxygenation requirements, being high flow, non-invasive or intubation. And those are really, really large figures. And really, I think two things we need to take from this is how can we alter this mortality, and how can we in future pandemics, which we are likely to see, not have this kind of damage. So what about in South Africa? While there are some stats available, of course, through the NICD that we get frequently, but there was a specific study done across numerous ICUs in South Africa, the ACCOS study, which was published in the Lancet in May of 2021. And there, the hospital mortality of patients admitted to the intensive care unit was 48.2%. And really what they stated the most likely predictors of poor outcome were comorbidities and a delay in admission due to resource constraints. And I think that second one is certainly something that we need to look at in future in terms of pandemic preparedness. So what does alter mortality? Because that is really what I'm not here to just give you the grim picture today. What can we do to decrease mortality in the context of COVID-19? And in my mind, I see this in three different sections: prevention, management, and collateral damage So I'm going to go through those briefly. Of course, this is a topic we could spend a day on, but I will just briefly touch on these issues. So the first thing is vaccination. And despite all of the hesitancy and all of the controversy and all of what social media has cost us in terms of conspiracy theories, etc., we know that the single most important thing we can do in COVID-19 is to prevent infection to start with. And if you look at, it doesn't really matter which vaccine you look at, there is mortality data. They vary a lot in terms of preventing mild and moderate disease, but there is, through the board, excellent evidence of patients who received vaccinations and who actually survived. And I think all of us as clinicians saw this. We saw that after Delta, in our fourth and fifth waves, the people we were admitting were either coincidental or they were the unvaccinated population. So the pictures that you can see, the first one refers to those who are not immune compromised. So clearly survival as time goes on better in the vaccinated group. This played out for the immune compromised as well. And of course, this was one of our concerns. Was vaccination really going to be effective in, for instance, our population with HIV? And we have shown that it is. The other thing that this breaks down is by age group. So yes, marked difference in those above 65. But probability of successful discharge in the young between 18 and 64 was also significantly higher in the vaccinated. And this remains a message that we need to drive to our patients. And I think that we have the responsibility of reviving vaccination programs really across the board, because I know other diseases are also suffering from all of the issues that happened around COVID vaccination. So this is the preventative part covered. Now, if we get to treatment strategies when a patient is actually admitted with COVID-19. And I think this has been the most murky area, the most up and down area. We went through fads and phases. We had publications retracted because everybody was looking for that magic medication, that bullet that you could give patients and that would save lives, that would save ICU resources. So what I've done here is basically I've just divided the severity of illness and time course and what works where. So of course, one of the major issues in determining what really works is the heterogeneity of studies. Studies were performed in various centers with various doses, various timing. And I think it's important to understand that there is a role for precision medicine rather than blanket medicine when it comes to COVID-19. So in the initial viral replication phase or the viral response phase, we know that there is potentially a role for the antivirals, but we've got to catch them early in that early phase and really probably target that, which is quite an expensive therapy, to those who are at high risk of developing severe disease. And at this stage, immunomodulators are actually contraindicated. So this blanket approach of giving everybody oral prednisone the minute they were diagnosed really for us in the ICU caused a bit of chaos because we were seeing patients presenting really ill when they actually went into the pulmonary phase because of inappropriate immunomodulator use earlier. When you get to that so-called cytokine storm and the host inflammatory response where we saw CRPs increasing, interleukin-6, if you had the luxury of measuring that, increasing, this is really where the immunomodulators were of importance. In other words, where we move from the viral suppression or antiviral drugs to actually just cooling down the immune response, because we know a lot of what we were seeing in terms of multi-organ failure, ARDS, in the ICU was related to the host immune response rather than to the virus itself. And this is where there's some evidence for immune modulators to actually alter mortality. So in what has been studied, and I mean, I can't go through everything that has been studied. We all know the various fads, the phases where we were going to use chloroquine. We had the phases where we were going to, try and give everybody remdesivir. We had the whole controversy around these drugs. But if you're going to, in the viral replication phase, there might be a place for antivirals and then monoclonal antibodies. And I think the monoclonal antibodies are expensive. They should be targeted only to people at high risk, and they must be used early. If we give monoclonal antibodies to a patient who's already been infected, where all their ACE receptors are already occupied by a virus, there's not really any point. And I think that's important. By the time a patient is hospitalized, these drugs are unlikely to be effective or show any mortality benefit, in fact. Then we get to the cytokine storm phase, and really these are the kind of patients that I saw in the intensive care unit. And the most effective strategy that we had available in the cytokine storm to prevent mortality was corticosteroids. So again, in the studies, there are various doses that were used. There were various products that were used. But I think we had good evidence for dexamethasone for 10 days in our hospitalized patients. And we only used that when patients had requirements for oxygenation or mechanical ventilation. So again, this is a targeted therapy to the group where they actually make a difference. An indication for steroid use in this would be acute hypoxemic respiratory failure. And then we also, I think in brackets I put there must be a true increase in oxygen requirement compared to baseline. Because if you have a patient who's, known with a baseline from a COPD, which was quite low, these were the patients where it was difficult to decide whether steroids really are indicated outside of the actual, if they had an exacerbation of COPD and it was indicated in that context. The requirements for mechanical ventilation, we had all our patients who were mechanically ventilated using steroids, and it certainly did make a difference in terms of mortality. And of course, we were still using steroids when we would usually use them. And this would be in, for instance, your asthma exacerbations, or like I mentioned, your COPD exacerbations. The IL-6 inhibitors like tocilizumab, these drugs are very, very expensive. So really, they were used widespread in high resource settings more than having availability, really. And I'm thinking of my unit. We didn't have that available broadly in states, but I know many of the private ICUs did have it available, and I had some experience using it on per patient basis. I attended a combined meeting with some of our colleagues in India, and they had IL-6 inhibitors freely available, and they were actually using this in all hospitalized patients with COVID. And again, the use there caused more chaos and more actually increased mortality when it was used as a blanket approach, because they were seeing then lots of gram-negative sepsis following because of the significant immune suppression caused by the IL-6 inhibitors. The JAK inhibitors, similarly, they have to be tailored to the period of the cytokine storm if they are actually going to alter mortality in a positive way. So I have borrowed this from the Internet Book of Critical Care. For those of you who are in critical care, Scott Weingard's group, EM Crits, had fantastic constant updates on what was happening worldwide and how the evidence was evolving. So for many of us who were literally at the front line and, evenings were reserved for reading, it was great to have somebody update the literature the whole time, and it was an easy, accessible resource. I love this because it's a visual representation of what we were doing. And oxygen therapy is something that we know was widely used. And in fact, many of our centers ran out at the peaks because we had such high use. But how we looked at oxygenation therapy was really also a bit of a pendulum swinging, because initially we were scared to intubate people. We felt that committing to them to a ventilator potentially could increase mortality. And as we went on, I think we learned that everything we were doing before COVID, we should have been doing during COVID. So our approach changed to, if a patient had an indication for ventilation that we would consider outside of COVID, we started intubating them. And really it was about titrating your oxygen. So we used a ton of high flow nasal cannula, and there's also good evidence that actually does alter mortality. That works a lot better for us than CPAP or BiPAP, because firstly, it's very user friendly. We could use this in non-ICU settings, which we needed to, and I'm sure most people on this conference also at some stage needed to manage patient outside of the ideal world. When we went for invasive mechanical ventilation, lung protective and ARDS strategies that we usually use were preventing mortality. So low tidal volumes, permissive hypercapnia, prone positioning. I know that prone positioning saved many lives in my unit because it allowed us to oxygenate patients without the kind of high pressure that would cause damage like pneumothoraces, etc. ECMO, while that wasn't available to us, so that was really easy, but really the indications have been very unclear and the outcomes have been really poor in the literature. And I've heard it said that for ECMO, really COVID has actually done quite a bit of harm in terms of the data that was available. Right, the other thing where we had differing opinions about mortality and influence of mortality is anticoagulation in COVID-19. So we know that abnormal coagulation studies meant worse prognosis. And initially we went for giving everybody high dose anticoagulation. And then we realized, oops, you know, patients with COVID can also bleed and they get bleeding complications. And we sort of swung the pendulum. And again, at the end of the day, the take home message is if anticoagulation is going to prevent mortality, it has to be in an individualized context. And right now, we initiate everybody on prophylactic doses. If we have proven or suspected evidence of venous thromboembolism, which is commonly associated with COVID-19 infection, then we went for high-dose anticoagulation like we usually would. And initially, we were discharging patients on anticoagulation through the board, but we also stopped that and really only targeted those patients at high risk. And if you do that in a targeted approach, then anticoagulation actually improves outcomes. So what about the collateral damage? So I think in terms of managing complications of COVID-19, if we did that well, then we could alter mortality. I think when everybody got over the initial fear of COVID-19 and the exposure to it, and we got back to doing things like we would usually do them in terms of, you know, managing complications, and people weren't as afraid anymore, like in the beginning, of managing patients with COVID-19, dealing with the collateral damage and really the complications we were seeing was as important as was our interventions. It was important during this time, and I kept telling my registrars, don't become COVID fixated, because we forgot about things like TB, PJP, malaria, all of these diseases that didn't actually go away really were problematic. And if we're going to talk about mortality in COVID-19, we have to not ignore other diseases that were still going on. And then the major collateral damage that we will pay the price for in times to come is that of antimicrobial stewardship. So how can we alter mortality in COVID-19 is we can keep our stewardship principles as they should be. We know that Augmentin and Zithromax have no effect on COVID unless you have a secondary pneumonia. Yet through the board, many doctors were prescribing these antibiotics to patients, and we are now seeing widespread resistance. We are seeing in Gauteng certainly the kind of antimicrobial resistance and multi-drug resistant organisms that we have not seen pre-pandemic, and we have to address this if we're going to alter mortality. So what about the morbidity? And I'm going to touch on this briefly. I know I have limited time, but the so-called long COVID and of course the complications of COVID. And we know if we look now at the literature, I'm just going to pick some of the large groups of complications that we see, but we see myocarditis in young patients who didn't have severe COVID. We know that your risk for having a myocardial infarction or heart failure increases significantly after having had that cytokine storm, after having this inflammatory response. And we have to, if we're going to alter mortality, deal with those and look for those complications and not assume that things are just, you know, sort of lagging from the initial COVID infection. Pulmonary complications after COVID-19, we know that can be divided into airways disease, into lung fibrosis, into chronic cough and just debilitating symptoms for the patients. And if we're going to improve outcomes, we have to consider those too. I'm going to touch on long COVID. I think this is something that is going to be very important in the months to come, because we have a lot of patients who don't necessarily have a complication of COVID, such as a pulmonary embolism or a myocarditis, but there are still significant functional impairment among these people. And if you look at some of the studies that we've seen, is that more than a third of people are experiencing persistent symptoms beyond the 2 weeks where they had the so-called acute COVID. So by definition, a long COVID really means 2 months after you should be recovering, and you're not yet. And if you look at the literature, the prominent themes are fatigue and the so-called brain fog. And I don't know how many of you have had COVID, but that is real. That was one of my persistent symptoms. Just, I struggled with names, etc. And it's very frustrating, especially when you're in a high level, high stress environment and you have to be functional. Dyspnea is common. And of course, this means we have to investigate the dyspnea, because dyspnea can be pulmonary emboli related, it can be interstitial lung disease, it can be a myocardial insufficiency. So again, if you've done all of those investigations and a couple of $1,000 later, you say to the patient, well, we just think, give it time and have some green tea, this becomes quite an issue. Chest pain and tightness is also a common symptom, and then persistent cough, which can really be debilitating, especially when, everybody is afraid of COVID and you don't stop coughing and they assume you're spreading it. So what are the issues around the morbidity of long COVID? Well, I think we have to consider the cost to healthcare. Because to be very honest with you, many patients that have been referred to me as long COVID, I have found complications such as pulmonary emboli or persistent lung fibrosis after their initial ARDS, or a myocarditis. And really, these are not cheap investigations. And it means many specialties are often involved. And this is really going to burden an already stretched healthcare system. What about the loss of income? So if you cannot perform as you used to, people are very compassionate when you have an acute COVID and you're lying in bed or you need oxygen. But it's very difficult for employers out there to understand why you're just not performing like you used to. The COVID is over, you're not on oxygen, your bloods look okay. Why are you not performing as you should? And for many people, this has actually resulted in being able to work less and having to cut down, having to cut back. Which can really have an impact, of course, on that person, on that family, and in the community. I mean, we are in an economy trying to recover, and it's important that we are all able to contribute to that. So long COVID in terms of morbidity, the space on how we're going to address that and what we can really do to improve that is really one we're all actively researching at the moment and looking for answers. So hopefully in future, we'll be able to present that. So in terms of preventing morbidity, what do we have to date? Well, the best way to prevent long COVID or the complications of COVID is, of course, not to get COVID. And whether or not vaccination helps for long COVID was controversial. But if you look at the meta-analyses that are coming out now, it does seem that vaccination certainly does. Outside of preventing the disease to start with, people who are vaccinated are less likely to develop long COVID or to have it for a shorter period of time. And then, of course, your usual preventative measures are in place. And that is really, if we can decrease the severity and the incidence of COVID infection, that would be how we prevent morbidity associated with it. My last slide on COVID morbidity and mortality, I think we have to also look at our healthcare workers. So this is my team. I am immensely proud to have been part of this team. And I think we, especially during the peaks, there was a lot of strain. We lost colleagues. I'm sure everybody on here knows somebody who succumbed to COVID-19 while they were on the front line. And we suffered a lot of morbidity in our healthcare workers as well. And I'm talking about physical morbidity, long COVID, pulmonary emboli, debilitating complications. But of course, there's a lot of post-traumatic stress disorder. There are a lot of people who have left the profession. And I think this is a crisis we need to consider. And there are a lot of people leaving the country as well. So we have to focus on morbidity and mortality among our healthcare workers. And we've recently done a cohort study where we looked at antibody, T cell and B cell responses in our healthcare workers. And it is clear that immunity actually waned over 6 months in 1/3 of our population. So we should probably prioritize our healthcare workers for boosting, and we also just need to address those collateral issues of resilience, of post-traumatic stress, of self-care. And I think in future pandemics and preparedness for pandemics, this is an important aspect to consider as well. I thank you very much again for the opportunity, for your time, and I would be happy to take any questions or comments at this stage.
Thanks very much for that presentation, which was very informative and very helpful. Maybe, Shali, would you want to take, I didn't see anybody who is actually posing any question, but from my side, the forest plot, I see that in January to March, it was significant, but the other months, April and May, it was not. Maybe what was the difference? What was being done correctly?
So thank you. It's a very good question. So this is international data. South Africa weren't actually part of those cohorts or that study because we had very little data. I think two things really. Well, the first was vaccination that happened much earlier in other countries, as you know, and through the board, I think it doesn't matter which country you looked at, they reported a decrease in ICU admissions, length of stay, and deaths. And I think we really did. The other thing that happened in the meantime was the use of corticosteroids. So the initial trials that came out, people were initially very worried that, you know, giving steroids to a viral infection, we know what it does in influenza, etc., whereas contraindicated. So I think the two big influences there were vaccination and the use of steroids in those who warranted use.
Thanks very much. Thanks a lot. That makes a big difference. You even said that in the cytokine storm, when we went to India, there were things which were actually available to actually combat the cytokine storm. But what was making us not having all those resources, because that was the main problem for those that we have lost. May their soul rest in peace.
Yeah, absolutely. And I think it was driven by cost and availability. So, I mean, this is outside the scope of this topic, but I think in terms of health equality, and equity, really, this pandemic has put a spotlight on the fact. I mean, initially we were afraid PPE was being diverted away from poorer countries because the rich could pay more. And sorry, there we go. My video on, it was cost driven. These are expensive drugs. So one shot of tocilizumab is in excess of 10,000 at some stage, I was told. So really, if we looked at the kind of difference it was going to make in saving lives, we needed to justify that cost. And I think we also probably need to start looking at producing things locally in South Africa. We have capabilities in South Africa. Our scientists showed that. We were at the forefront of some of the variants. And I think, yeah, it's really, at the end of the day, it's health economics.
Thanks very much, Prof.
Prof Ueckermann, there's a question from Dr. Matala in the chat. Was there any way besides comorbidities in terms of blood work to predict deterioration to severe disease in early COVID?
Okay, so blood work, we were quite reliant on the inflammatory markers to predict who was going to get worse. In the first two waves, who we initially thought would get worse didn't get worse. So in terms of comorbidities, maybe just to address that first, that was a huge shift. In my setting, we have a very high burden of HIV, for instance, and we were very worried about those patients. And in fact, they did much better than patients with obesity and hypertension. So that was the things that we found clinically in our studies, and that is currently in preprints to predict outcome were diabetes, obesity, late presentation. So if you were, we were a referral center and we were taking masses of patients. I mean, we at one stage opened 4 ICUs, but even with that, if there was a delay in transfer and a delay in presentation, those patients deteriorated a lot faster. Having said that, I've worked in ICU for over 10 years, and I am used to being able to predict at the bedside who I think is going to get worse and not. And COVID very frequently, actually, our usual prediction scores didn't work. So we relied on the ROC score, basically on patients in high flow, to predict who was going to be intubated and ventilated. There's some evidence that maybe the quick SOFA in the international literature helped us to predict who was going to deteriorate. But again, we tended to look at the patient's trends. We were very pro early self-proning, and I know there's an article recently which showed it didn't make a big difference. I think if we contribute our data, we might be looking at something different. If that didn't work, initial response to therapy didn't work. Those were the people who didn't do well. But if there's one thing I can say about COVID-19 is it doesn't follow rules. As soon as you think you've figured it out, then the next wave comes and the prediction rules changed. I hope that answered your question.
Thank you. I think the only thing we can be certain about is the uncertainty of the condition, isn't it? I'm sure you must have been puzzled or amazed all the time at, say, older patients coming in.
Absolutely.
And yeah. And then younger patients that we thought would do well, just would crash so quickly. A question from Dr. Mugafe: how effective is viral load decrement? I'm sorry for the echo. Via nasal syringing and antiseptic throat gargling in containing the morbidity of the infection?
So I haven't seen any randomized control data on that. I have seen some case reports and small case series that had a signal that this might be, there might be benefit. However, I've seen patients doing the extreme, people were, trying to sniff Listerine and all sorts of things like that. So in terms of physiology, it does make sense that would decrease your viral load. But I haven't seen any randomized controlled data to really recommend that. But yes, it's certainly something interesting to look into.
We have a hand up from Dr. Ntlapo.
I have with me Dr. Peter Mabua, and has a question for Prof Ueckermann.
Yes.
Good morning, Prof.
Good morning.
Prof, I just want to find out which ventilatory mode did you prefer for your COVID patients? And the second question is, was it pulmonary embolus or pulmonary thrombus? Because all patients who were sent for CT scan from the ICU, they'll come back and the report would say pulmonary embolus, but the D-dimers will be normal.
Yeah. So it's an excellent question. So let's start with the ventilatory mode. So I teach my registrars the safest mode to ventilate is the one you're comfortable in. So I like a pressure targeted mode because I think in any patient with ARDS and severe lung injury, we want to prevent barotrauma. So at least if I know the pressures are low, we allowed for permissive hypercapnia, we allowed for permissive hypoxemia, provided, of course, that there was adequate perfusion to allow tissue oxygenation. So for me, the pressure targeted mode was the easiest because at least then I know that no matter what happens in terms of compliance, we will be able to, limit the pressures delivered to the lung. And again, the patients who did the best worldwide were in units where everybody could have an ICU specialist. I don't know what your hospitals look like, but in my hospital, everyone from orthos had to join eventually. Of course, we didn't let them do the ventilation, etc. But it wasn't always, there wasn't an intensivist at everybody's bedside. And we had fantastic ICU nurses who were also able to, so with each gas, we would adjust and try and keep up it. The main thing was to limit damage, barotrauma, because once you have barotrauma and fibrosis, we are in trouble. Then the question of pulmonary thrombus versus pulmonary embolism. Great question, because if you look at the post-mortem studies that were done, especially in Italy, they were finding a lot of pulmonary thrombosis. And a lot of the so-called pulmonary emboli that we were seeing as well, we couldn't find peripheral evidence for deep venous thrombosis. So that usual. So, and of course, it begs the question, we were treating them all like PEs, but should we be treating pulmonary thrombosis differently? And one of the things that would really makes it difficult is very often patients were presenting really late. So trying to sort of backtrack to the initial event, whether this was really thromboembolic in nature or primary pulmonary thrombosis, which has been described in the literature, would be difficult to distinguish, but it is an excellent question. Unfortunately, I don't have a clear answer to that. I think both probably happened.
Thank you very much, Prof.
Pleasure.
There are 2 more questions in the chat. Can you explain us the possibility of microclots formation in the brain on long-term COVID? And then what determines the success of weaning off ventilation as convalescence sets in of ventilated patients?
All right. So, again, great questions. You've got a great audience here. So microclot formation, I think the microcirculation is where everything is at in COVID and in terms of long COVID. So, I mean, we're starting to dabble in long COVID, and my colleagues in immunology and hematology have really produced some interesting work in terms of, if we look at that thromboinflammation. Now, we know that with any huge inflammatory disease, sepsis, etc., there's this thromboinflammation that occurs. And thromboinflammation is really at the heart of the pathophysiology of the multi-organ dysfunction of COVID, and I would suspect of long COVID as well. So obviously we don't have, we can't look at the brain microcirculation and the pulmonary microcirculation, the heart microcirculation, but if we look at the manifestations that follow, for instance, your increased evidence of cerebrovascular illness afterwards, if you look at the MRIs of patients who had COVID without even neurology, there was that series that was done in the UK where they looked at CT scans of patients before COVID, then they had COVID without any neurological manifestation, and there was actually a loss in brain volume loss and some small vessel vasculitic changes. We have to assume that the microcirculation is definitely involved in the process of long COVID. So what we're seeing is these I like to call them angry platelets, like you usually see in a myocardial infarction. It's these hyperactive platelets. And when we first started with some of the immunology of COVID, we collaborated with the NICD and we sent samples to them. And one of the people from that side phoned me and they said, this is insane what we're seeing. We've never seen this. You guys have to use steroids. It's got to be that steroids will work. So where this hyperinflammatory state has to lead to small microclots. And I think that has a huge impact on the long COVID. The question is, should we be putting everybody with long COVID on anticoagulation? Because, you know, if you do get a complication from that, it's very easy if a patient has a clear documented thrombus or embolic event and you anticoagulate them, you're safe. If a complication occurs, it was justified. But where are we in terms of a risk-benefit ratio with long COVID? And I think those are incredibly important questions which we need to research and answer. Then with regards to the second question about weaning, so in ICU, we know that the things that impair weaning is prolonged ventilation, steroid use, and paralysis use. So for the majority of our very ill patients, we were using all 3 of those. So weaning did become a huge problem because it took time for that inflammatory process to settle. They were all getting corticosteroids, which creates some degree of weakness. They were all, most of them actually received paralytics at some stage just to get them oxygenated. So one of our most difficult things was prolonged weaning. And of course, things that usually impair weaning applied here too. So if you think of in an ideal setting in our ICUs pre-COVID, we have this incredible team that goes every day and we chat around the patient, and the physio says, okay, I'm doing X, Y, and Z. And then the dietitian pops in and says, I'm going to increase the protein. And that was not the environment we were working in. So we had, we were also kind of overwhelmed by keeping the patient alive, that all of those things we would usually do, delirium prevention, to improve the weaning process, weren't being done as ideally, perhaps, as it usually would have been done. But in terms of getting patients off the vent, you want to make sure they get adequate nutrition. You want to limit paralysis as short as possible. You want to get them taking at least some spontaneous breath and doing some of the work as soon as possible. You want to wean as aggressively as you can. And then you want to prevent secondary infections, because those were a major bugbear for us. So once the initial COVID is over and we're weaning them, they were getting secondary gram-negative pneumonias, which were often quite drug resistant and would put them back onto the ventilator or more requirements. So I think in terms of predicting weaning, it's really the severity of disease and comorbidities. Again, our patients who are sarcopenic, who already had low muscle weight mass, who were not eating well at home for 5 days prior before they became really sick. All of these things contribute to whether or not a patient will wean well. Thanks.
Thanks, Prof, for those educative ways of doing things, especially in ICU, because as we know, most of our patients, it's actually, COVID is a lung disease. So ventilation becomes the most important thing. That's how it was. But there is also this ventilators which people use the mode, the ASV mode, mostly in district hospitals, because they think that that is, at least they don't have to be worried about SIMV and all that other things, because the ventilator can actually adjust everything for the patient. What's your take on that, especially when it comes to COVID?
Yes, so I think, first of all, if you had the ventilators with that capability, great. So I didn't. So we had to go on our usually, again, especially in COVID, where not everybody was necessarily comfortable with ventilation. And I think most of us as intensivists had quite a broad consultative availability, because I had ComServe doctors sometimes ventilating and if they can chat. So ASV is a great mode. It is actually created as a weaning mode. So it's really almost like artificial intelligence, where the ventilator will sense, oops, okay, the patient needs a bit more support, or the patient needs less support. ASV is not something that I would use in a patient who was sedated and paralyzed. So in the severe ARDS, it's not an ideal mode, but it is a fantastic weaning mode, especially, as you say, in a high volume area where everybody can't necessarily be weaned by an intensivist.
Prof, I
don't know if our next speaker is around. Sorry.
No. Are we looking at quantifying the condition? And what I mean by that is, I think we've seen it in other very non-specific conditions, often when the diagnosis is one of exclusion. And it takes a long time for it to be accepted. As you pointed out now, you're sympathetic when your staff member, your family member is ill, but now you want them to get up and get going, and it's like fibromyalgia and yuppie flu. So this is so non-specific,
It is.
And yet it's very, very real for the individuals. And you mentioned, colleagues, you said, the brain fog. So I've been encountering this with colleagues and it's a double struggle, because they're so determined now to get up. They see it as a weakness in themselves. And because there's nothing definitive, I think it just makes it that much more difficult.
Absolutely. And, you know, it's also so pleiotropic in its presentation. Like if everybody had a long-term cough, you know, but some people will come with, like you say, fibromyalgia. They've just got this pain. And literally, I have such sympathy when I work with patients, and I've done lung functions, CT, I've excluded a PE. Some of them have even had cardiac MRIs because I'm so desperate to find something. And I have to look at them and say, everything's normal. And I see these people break down and say, but it can't be. So I think the first step would be awareness. And we need urgent research, because what has been, it's defined, no matter where, if you look at the Americans, if you look at us, we're all defining it differently. And it is so costly to research, because you must first make sure all those complications are excluded. But it's real. It definitely is real.
And I think awareness is important, but also now starting the write-ups, because if you go back to the history of HIV, it was a case study that became a case series that then defined it.
Absolutely.
And you know, you're hearing anecdotal evidence from different specialities, from orthopods who say now patients present with joint pain, or
Absolutely.
Dr. Mawea, over to you. What would be the way forward?
Yeah, they said that the next speaker is not ready. I think we've exhausted most of the questions. Maybe we must ask, we can ask the people at that office as to what is the way forward.
I know, Prof.
Dr.
Basu.
Mawea, sorry, Dr. Mawea, we've got a pre-recording for Dr. Shange, so we can go to that now.
Oh, okay. No, that's fine.
Good morning, colleagues. Thank you very much for giving me this opportunity to give this talk on management of multimorbidity in primary health care. I first wanted to start with the definition of multimorbidity. Though there is no agreement on it, but the ones that I chose are these two, is the coexistence of two or more chronic health conditions in an individual, any one of which should be a long-term physical non-communicable disease, a mental health condition of long duration, or a long-term infectious disease. For instance, you could be having a patient who's having diabetes, hypertension, cardiometabolic disease, and also on long-term HIV treatment, and also maybe with a mental disorder. And then these patients also, they become a little bit complex. It's the patients for whom clinical decision-making and care processes are not routine, or standard recommendations from evidence-based medicine unlikely to apply in a straightforward manner because of exceptions such as multiple interacting chronic conditions and socioeconomic conditions. So they're not really easy patients to deal with. Why multimorbidity? We see that an average primary healthcare practitioner, when they sit with a patient in front of them, quite often it's a multimorbidity patient. So longevity has actually made patients to have multiple chronic conditions because people are living longer. We give people HIV medication that makes them to survive longer. People survive their myocardial infarcts and they survive into old age. Ultimately, they develop multiple chronic conditions. But also socioeconomic factors exacerbating medical illnesses. So you find a lot of patients who've got problems of living presenting to us as medical illness. And most importantly as well, we live in this day and age of mental illness. It can also exacerbate medical illness. Challenges. We're finding that multimorbidity is becoming common and burdensome, as I've mentioned, and is becoming the norm, that most of the patients that we see are chronic multimorbid patients. There's also variations in definition and reporting and measurement. For instance, in this article by Fulp, he actually does allude to the fact that there's no agreement in terms of how do we measure this and how do we report it, even the definition. But what we've found is that multimorbidity patients are usually excluded from clinical trials. For instance, when you find your randomized controlled trials, most of the times these patients are an exclusion, And also, we don't see trials where there's polypharmacy being used a lot in multimorbidity patients. But also our systems are configured for individual diseases. We don't have systems or clinics where we treat multimorbidity patients. And also we find that our practitioners are underutilized in the public system for this. The worst of them all is the fact that there's no continuity of care. There's no shared information amongst treating doctors. A GP will send a patient to the hospital with a referral letter. There's no referral letter coming back to the GP. A clinic sister will send a referral letter to the hospital. There is no referral letter coming back to the sister at the clinic. What used to happen in the past, they will have tear of slips give to the patients, but the patients never brought them back to the clinic sisters. Some stage, I remember in my hospital, we used to put all the tear of slips of all the clinics together, and then we put them in an envelope, and then we deliver them to the clinics. But then the clinic said, no, when you bring them in a pack, we don't have the time and resources. Someone must go in and pull out those files to put back those report backs. But at that stage also, some of those report backs were no longer relevant. So there's that discoordination. The other challenge is that most of the time, these patients are seen by nurses at the clinic who are trained in primary healthcare with support from doctors in the clinic. But we find the doctors are clinic-based. They don't usually go out with the sisters who are doing the ward-based outreach teams. Those are our community healthcare workers, to go and look into the families of those patients in terms of what is happening in their homes. They only see the patients at the clinic and what they see at the clinic, and they treat what is in the clinic. But there's no integration between the systems. There's also no communication, no sharing of data. But we find that patients cross systems. So they use the public sector, they use the private sector. There's no sharing of data. So nobody knows what the patient is on. If the patient is consulting you as a GP, you don't know what they are on at the clinic. Even the clinic, they don't know what the patient is on if they're also consulting the hospital. So there is that problem. And we find as well that this evokes a reaction in the clinicians. CJP uses the term complexity. He says complexity is what I feel when I don't have an algorithm for what's in front of me. We are used to having algorithms for hypertension, diabetes, HIV, etc. But now we have a patient who's got these 5, 6, 7 conditions, and there's no algorithm for you to be able to have these patients. And why don't I have an algorithm for complex patients? It's because our algorithms are for diseases, not persons. One would wonder, patients are not the same. Why do we want to treat them the same? I really wonder. At the end of the day, we end up giving labels to these patients, and then we say, oh, it's a heart-sink patient, it's a difficult patient, it's a non-compliant or a non-adherent patient. And then when we look at some of the ways that are being suggested for managing multimorbidity, if you look at the word, it's multimorbidity. So multi, in other words, it means also the management should be at a multi-level. Can never be at a single level or in silos with one person. So it's a multi, so it's multiple levels, both at individual population level. We want to promote interactions with communities as well, and we want to interconnect with all stakeholders in the healthcare ecosystem in the form of multidisciplinary teams. We can talk about this later if time allows, even also through the Q&A section. But also want to target prevention services to those at higher risk of disease. Because if we don't do prevention, even the resources that one might have for managing multimorbidity would be quickly finished if we don't prevent more people getting to the level of multimorbidity. Also, holistic prevention measures and early identification of complications. If I've got a diabetic, I must make sure that regularly they get tested, their eyes to seek for complications, see a podiatry to make sure that they don't end up with unnecessary amputations. And also we need to target the sickest complex patients. What usually happens is that if you look, the most sick and the most complex patients, that small number is the one which is taking a lot of our time, a lot of our resources. So if we can at least concentrate on those patients and then make sure that we manage them properly, we will have enough time to manage the other patients and also save resources. What we can do also is to regularly review current multiple drugs that we have. If you look at a common file in a hospital of a patient, you'll find that in the treatment section, there will be about 10 to 20 drugs. By the time the patient goes to the pharmacy, there's a list of about 20 drugs. The patient has been to MOPD, patient has been to cardiology, to rheumatology, to immunology, all of these clinics. And at the end of the day, they end up with this long list of drugs. At the end of the day, doctors also don't want to remove medication that has been prescribed by another doctor. So they just add onto this list without really checking if there will be drug-drug interactions, and no one wants to take responsibility for sorting out this prescription. This is what Michael Balint calls the collision of anonymity. Even in private healthcare, this happens. The patient goes and sees this specialist, that specialist, that specialist, that specialist. They all give treatment, but no one is actually organizing that treatment, and no one is removing the treatment that was given by the other doctor. So we need to do comprehensive evaluation of each patient, assessing not only their clinical problems, but their functional, cognitive, behavioral, and socioeconomic issues. We found that a lot of the issues are related to psychosocial issues. So they may be presenting as clinical issues, but we need to look into that background. What we do in a situation where I work, we do use a lot of the community healthcare workers who work to help the team to get into the background of the patients, to see what are their preferences, their constraints. Then they help the bigger team to have a deeper diagnosis and to understand the patient better. And once this is done and we've concentrated on these patients, then we're able to transfer the stable chronic patients onto the CCMDD, which is the program that helps us to reduce workload and waiting times, where patients can collect their medications maybe for about 5 months, and then on the 6th month they come back and they are reviewed by the doctor at the clinic. What we want also to use most of the time is this work by Nigel Stott, found in this journal, in terms of saying in each consultation, we may not be able to finish everything at once, but at least there's a potential in each consultation. So at least when I see this patient, number one, I need to manage the presenting problem, why the patient is there. But at the same time, I need to continue managing the continuing problems to make sure that they don't get complications from the chronic conditions that they have. So I do screening on those ones. Otherwise, the patient may have entered the system at the wrong level. I help the patient in modifying at which level they must enter the system, not forgetting opportunistic health promotion, that they might die from an undiagnosed cancer, a cervical cancer. So we do pap smears, breast exams, all of those things. Not necessarily at once, but we can have intervals where we do this, but you must always know and keep at the back of our minds. This is the potential that we have in each consultation. There are things that we need to avoid when we're treating multimorbidity patients. You see, with these guidelines and protocols, if we try to stick to them strictly, we may also have a problem of unintended consequences, because we may deliver inappropriate care for some of these patients because it may not be aligned to the patient's goals and preferences. And also we may cause harm with drug-drug interactions, with side effects, and patients may end up not adhering. For instance, if I don't ask these patients, I have an example of a patient who is a street vendor, and she's on chronic medication from the clinic. When she comes for other things, her blood pressure is always high. Then I ask her why she's not taking medication. She says, there are no ablution services in the street where I'm working, but this pill that they are giving me, it's always making me to want to go to the bathroom, so I don't take it. So it's always important to look at the context of the patient as we give medication. And I think what is important for us is we have to look at what matters to the patient. Sometimes we have this thing of wanting to collect data, and we also want to deliver systems according to a certain system's data. For instance, we may be wanting to push a patient to a certain HbA1c, certain level of a lipogram, CD4 count, viral load, etc. But we lose out on the patient-centeredness and goal-directed care. For instance, if we don't discuss with the patients why we would like your HbA1c to be less than 7, but we're pushing them, and we don't discuss the route with the patient to get to that level that we want. For instance, you may want to prevent certain risk factors, cardiac risk factors, then you find a doctor giving the patient aspirin, statins. Patient is going away with bags full of medication, but is asymptomatic and doesn't understand why I don't have symptoms and they're giving me bags full of medication. So we need to be able to reach that consensus with the patients and also be patient-centered. The one that I find quite often when we work with community healthcare workers when they do home visits is that quite often now they are using gadgets to take information from the households, but there's less touching, and I hear patients complain that they miss the touch. So a community healthcare worker will stand at the door with the gadget, ask questions, and the data goes and it's fed somewhere. I usually ask them, where does the data go to? No, I give it to my team leader. My team leader gives it to my operational manager, and then it goes to the central office at the Department of Health. But I've never seen anyone come back to the community to report back on the data that they've taken from the community, to say what has the data told them and what is it that the community can do differently once they've analyzed that data. And the community is complaining that they are not getting any touch. No one is checking my BP, no one is checking my sugar. They just ask questions and they're just looking at a gadget. So we need to change maybe the way we look at things. And also we have household fatigue. They are now tired because every other person is coming to interview them. For instance, we have community healthcare workers from the Department of Health, from the municipality, from the university, from the NGOs. Now we have what we call household fatigue. And we try to say, let's go together to see this household and group together, but then we find the problem. People report to different sections, and each one has got their own indicators and targets. And once they go together, they don't fulfill those targets. So they separate again. And then we do have linkage officers. The clinics do identify sometimes people who are not adherent or have defaulted. They do go to the homes. Those ones, a little bit, they help us in terms of reaching those clients. And what is also has come out in the multimorbidity patient work is that when you do that household visit, you do have questionnaires for the individual patient. But when you have a general questionnaire for the household, sometimes the reasons for poor management of the multimorbidity becomes clearer. Could be a go-go who has not been adherent. Then you find in the house she's taking care of 5 grandchildren, or sometimes she doesn't have money to get to the clinic. So everybody else is going to work. Everybody else doesn't get time off from work, and now she has to get stuck with these grandchildren and she doesn't come for her treatment. How do we improve adherence? Michael Brown from CDE actually says it's all about the patient. So we need to aim for our targets, our target HbA1c, target viral loads, but we need to negotiate the route to get there with the patient, which he calls collaboration. And we need to focus on the right agenda. Is it the patient's agenda or is the doctor's agenda? And we need to encourage self-management and self-care. A lot of these patients now, they have these IT things that they buy, gadgets. Some, even if they don't have small notebook with a pen, they can write their readings and say, once I've eaten this, it is what it does to my sugar. And we need to not act out of context of the patient. We need to understand the context all the time. So what are the feelings, the fears, the expectations of the patients and the concerns, and we need to work around that. And most importantly, we can't work alone. We need to use a health team. Like I've alluded, the MDTs or multidisciplinary teams who are faced with a new situation in the new world that we are living in. It's a changing profession, a changing society, demanding patients, educated patients who are Googling all the time, changing healthcare, new technology and innovations are in our way. So the question is, are we going to change, stagnate, keep moving, or are we going to die a slow death? We've got newer innovations. We've got nurses now opening their own primary healthcare clinics. Patients can go there. Even our multimorbidity patients go there as well. We've got corporates who have also opened these kinds of activities, giving access to nurses, doctors, and the innovations are coming in all directions, left, right, and center. And we need to deal with this when we deal with our patients. In my area where I work, I just want to give an example of what we've been using in terms of managing multimorbidity. We have a community health forum. This was also started out by an impetus from one of our professors who said to us, policies from above, yes, but the details must come from the ground. And we're trying our best to make sure that the details of what we want to happen to our patients come from the ground. So we work hand in hand with our local hospital, with hospital boards, clinics and clinic committees, NGOs in the area, the municipality in this area, and the ward-based outreach teams in this area, and the community-oriented primary care. So we are working together, even though they are vertical disease-oriented programs with some of them, but we are trying to work together. We have found in any case so far, we don't have resources for home-based care. So for this one, it has slipped through the cracks. And the gap that we have, which one will try and improve on maybe, is that individual GP practices and nurse practices are not yet connected to this community. There's only one nurse who runs her own primary healthcare who is part of the forum. And just a quick example of what we do, for instance, here, we have one of our clinical associates visiting a shelter and doing an assessment that we would usually do in a household. We have a community healthcare worker here in the streets with the homeless. We do a lot of work around substance use, but also they might be coughing and having other things. You will see there's a sputum buckle, and then she will collect and send to the clinic. Visits, patients appreciate. This is a way now you think about the patient agenda and preferences. Some of them, they prefer to have this home visit. And in this home visit, there is progress card where you write the notes, and also the treatment that is reviewed by the doctor every 6 months. And then the sister just checks the BP, the sugars, and then delivers the medication at home. And the doctor will review the prescription after 6 months. And then this is one of the patients I picked up at the hospital, because when she came to the family medicine outpatient, she was labeled as a non-adherent patient. Then I visited her with a community health care worker and a registrar in family medicine, and this is what we found when we said, give us your packet of pills. And you can imagine if this is your packet of pills that you have to take every day. But we tried to sort it out for her and to work with her and work with her issues until we tried to correct things, and she was happy to go back to the hospital and to be on time. Finally, one would like to think at what is the motto that one would look at for primary healthcare physicians when we're handling these patients. Most difficult patients start out merely as complex. If we can just understand what is the complex patients. Patients, clinicians, and families can't do their part in care plans they don't understand or embrace. It's very important that we walk with them this part. The right kind of time at the beginning of a case saves time over the life of the case. Take time, at least at the beginning, to sort things out. Patients' resistance is usually a sign of a problem in the approach, negotiation, or timing. It could be a communication problem. There's no need to make the patient give up their medical conception of the problem as a condition for working. For instance, they may have a reason why they have diabetes, but if they're willing to work with me, I don't have to change them from that reason. And later, maybe when we do behavior modification, it can come. Healthcare relationship problems interfere with healthcare treatments. We need to have good communication skills. And importantly, we need to hold the baton until we are sure that the next person has it and he is sure that he has it. So we need to hand over our complex patients, and then we need to groom patients for referral. Quite often patients don't know why they are being referred. I had another patient who had moved from my area to another area. Her husband had died. She was referred to a psychiatrist. She comes back to me and she says, you know what, doctor? I don't understand this doctor. He sits there, he's asking lots of questions. He doesn't address me. He doesn't check me. At the end of the day, he charges me more money than the money that you charge me, but he doesn't address me. What kind of a doctor is this? So I had to explain to her how the psychiatrists work. So this is important that we groom patients, even if we send them to other specialties, what to expect, and all the time. Way forward, I think we need action in the preventative public policy. Why it's important here is because they always say it's an addict, prevention is better than cure, but we can reduce the progression of patients reaching multimorbidity if we've got good public policies, and if we have our government coming to the party. And we need innovations to achieve high quality services. I don't think this will be able to do just using protocols, SOPs, and guidelines, as I've alluded. These are not well suited for our complex multimorbidity patients. There is a way we need to implement this to understand them, but just having them sitting on our desks are not going to help us to help these patients. So we need guidelines that are appropriate to person-focused care, but not disease-focused care. And I'm happy working in this sphere of COPC, where we integrate individuals, populations, and in another time, when there's time and when we have maybe Q&As, one can expand on how the COPC project is working, but it's excellent. It embraces preventative medicine, health medicine, and also looks at the community, and we talk to the communities, what are their demands, and it helps to look at the continuum of care of the community. So I don't know what you will do, but I think cooperation is the key to success. Thank you.
Thanks very much, Dr. Lindy Shange, for that presentation. Excellent one. Like I said before in the beginning, she's not here. So what we're going to do is whoever has questions can post them into the chat, and then they'll be collated, and Renier will actually send it to her, and then it will be answered in the material that is going to be distributed to everybody who's attending today. But the things that I would like to bring out from her presentation is the WABOTS, which is the ward-based outreach teams, which is going to be the future of primary health care in terms of the NHI, the National Health Insurance, in the universal health coverage, and also the CCMDD. But the most important thing is what she has actually highlighted is the holistic approach to healthcare. Don't leave the patient and then you say, okay, I know it all as a doctor. It must be patient-centered approach, whereby the patient must be involved in making the decisions for their care, especially in the multimorbidity, which is very, very common. The COPC, community-oriented primary health care, is the way for the future for primary health care when we have to talk about NHI, and also linkage to care for our patients, and also COSAP, that patient who a community-oriented substance use program. It's very, very critical, especially post-COVID. That's what we see. Most of our people are actually suffering from a loss of income, and then they end up with mental health care issues and substance abuse and stuff like that. So this is a very, very important presentation. Way forward, like she said, we have to actually involve the patient in all our decisions that we make for them. Charlene?
Absolutely agree. I think, it's the model to strive for, this comprehensive, holistic approach, both in managing and preventing. Shall we move on to Prof Basu now?
Good morning, Chair, and good morning, colleagues. It's a pleasure for me to present the South African National Strategic Plan for the Prevention and Control of Non-Communicable Diseases, which will drive how do we manage, control, and prevent non-communicable diseases in South Africa for next 5 years. I'm making this presentation on behalf of my colleague, Mrs. Sandhya Singh, the Acting Chief Director for the National Department of Health. Before I start the presentation, maybe I should use the language what is talked about leaving no one behind. What it implies is that we take explicit action to end extreme poverty, curb inequalities, and confront discrimination and fast-track progress for the furthest behind. And it is extremely important when we are talking about the management and control of non-communicable diseases, which is beyond just the plethora of the Department of Health. I'd like to acknowledge my colleagues from the technical working group who actually wrote this document, and also my other colleagues who actually contributed for preparation of this document. I'm going to talk about the background, the solution-based approach for the prevention and control of non-communicable diseases in South Africa. I'm going to specifically talk about the strategic plan, its implementation, and my esteemed colleagues, your role for implementation of this plan. And lastly, I'll make some concluding remarks. When we talk about the non-communicable diseases, we need to talk about moving the paradigm from the disease to the health. We need to talking about the health systems, the social care, and the health in all policies approach, which actually assist us in investing the integrated people-centered health services and putting the people and the communities in the center of the continuum of care so that we can shift the focus from the disease to the health. You will realize that South Africa has invested a lot for last 25 years for improving the healthcare access to the people. And if you can see, starting from the constitution and to the number of policy documents, legislation, guidelines, all of these leads to the better health outcomes. But what we have seen this, in spite of that, we still have low access to the quality services, inefficiencies, inequalities, and suboptimal health outcomes. If we talk about the chronic diseases or non-communicable diseases, what we have seen for last few years, since we coming out of the HIV epidemic, there is a sudden increase in the percentage of death, and which is becoming now unchanged over last few years. We acknowledge that there is an increase in the majority of the risk factors, which are preventable, but unfortunately they're increasing. We become an obesogenic society, particularly among the women, which is one of the highest in the world. We continuously seeing the increase of the social, economic, and commercial determinant of health, or actually the ill health, which requires an all-up health and all-up society's approach. And we have seen that whatever gain we have made, it actually gone undone by the COVID-19 pandemic. And you have noticed that the COVID-19 mortality and morbidity is significantly associated with the chronic diseases like diabetes and hypertension. The South African increase in the mortality is not aligned to the government responses. We need urgently to make a paradigm shift from the health, from the diseases to the health. We need to talk about the political and strategic shift, the shift in the health systems, in the population-based approach, as well as among the patients and communities. So when we are talking about the challenges and required strategic responses currently, the challenges, we can divide them into two groups: the general population, patient and communities, and particularly the population which is a risk to the high risk behaviors. And we need to talk about them and about their unawareness about different conditions such as hypertension and diabetes. We don't screen enough people because of various reasons. We fail to diagnose their conditions, and at the same time, there is a problem of self-management of the care, and there is limited patient and community engagement in terms of management of these conditions. But when the patient reaches the health facilities, we also notice that there are poor clinical governance, There is limited accountability in terms of the NCD outcomes. There are poor surveillance in comparison to the diseases such as HIV, and there is non-evidence-based funding model that which is actually affecting the management of the NCDs in South Africa. So how do you manage this process? Firstly, we need to agree that we have to do something different to meet our SDG 3 targets, which is focusing on the chronic diseases. We need to have an integrated patient-centered health approach because the government or Department of Health alone could not address all the problems which we are facing. We need to talk about the multi-sectoral action from the government, different government departments, civic societies, as well as organizations like South African medical associations, which we can all work together to achieve these targets. One of the key cornerstone of this plan is cascading. We have seen the effect of cascading in the HIV/AIDS epidemic, and what we have proposed in this plan is about a similar model for the NCDs, and which I'm going to talk about it later in more details. We need a innovative, equitable, and sustainable funding for NCDs if we really need to make this happen. Just to understand the cost or economic cost of NCDs, and we cannot not attend to it. Just to give you an idea, around between 2006 and 2015, we spent around 26 billion rand for the various conditions such as diabetes, stroke, and coronary heart diseases. In just for 240,000 type 2 diabetic patient, we spent around 2.7 billion of our health budget in 2018. Prevent and control the NCDs in South Africa. So we need to have a solution-based approach. What we mean by solution-based approach is that it should be inclusive process, that we need to have meaningful engagement, not just by telling that we are doing the community engagement. We need to include the community population through an integrated patient-centered health services, where the patients, the community, the population become the front of this approach. We need to have innovative funding model, such as we have seen that the sugar sweetened beverage and proposed NHI, which can actually manage some of this model. We need to have an innovative model. I already mentioned about the care cascading, that we need to look at it. We need to develop an optimal care platform and pathways at the community level so that the patients can benefit fully from it. We need to promote the continuum of care from the household to the primary healthcare facilities, by the general practitioners or clinic, right up to the hospital, and complicated cases to the central or tertiary hospitals, where we can offer more for tertiary services such as the transplant, etc. Secondly, we need to have a multi-sectoral approach to the non-communicable diseases. And we talked about the social compact. What is the role of the government, civic societies, business to create an healthy societies? The February 2022, the State of the Nation address called for a social compact. The idea is to grow the economy, create jobs, and combat hunger. The South African reality is, one hand, we have the hunger or malnutrition. On the other hand, we have obesity, diabetes, and hypertension. And this paradox actually is a major problem of managing non-communicable diseases in South Africa. So when we're talking about the NCD response, it requires the 3 C's, the chronicity, comorbidities, and the cost associated with it. And our argument in this plan is to manage the coordination of care, provide financial protection through the evidence-informed smarter investment, and the prevent disease and protect health and well-being of the population. Just to remind ourselves, the WHO health systems building block, and again, putting the people at the center of all the activities which is rendered for this, including governance, information, financing, service delivery, human resources, and the medicine and technologies. I mentioned about the systems approach to the strengthen the non-communicable disease management and the health services. It needs stewardship from the various sectors. It needs adequate financing. It needs a trained health workforce that which can differentiate between the prevention and control and the management, and shifting the focus from the curative care to the preventive care. We need appropriate medicine, the smart medicine that which can address the challenges of managing the non-communicable diseases, particularly at the preconditions like pre-diabetes or pre-hypertension. We need the digital technology. We cannot talk about the health systems in 21st century if we don't talk about the digital health. Digital health is the way to go. We have to understand it and we have to implement it. Some of the services, including that when we talk about integration of care from the household to the hospital services. I started my presentation of the leaving no one behind. So we need to start talking about the prevention and early diagnosis. We have seen that the killer disease about diabetes is not about the people die of diabetes, but they die of the cardiovascular complications. So if we can understand and identify the people at a pre-diabetic stage or an early diabetes, we can actually reduce significant mortality and morbidity associated with the diabetes. We need to continuum care from the primary to the tertiary prevention so that the patient can get benefit of every levels of care. We need to support the adherence. We have seen the challenges with the HIV treatment, and we have a similar challenge of managing the adherence to the treatment from the population side. The medicine should be affordable, not only the chronic care ideal, which we see, but even the tertiary care ideal needs to be affordable for everybody. One of the major challenges in South Africa is the multimorbidity, which you used to see a patient coming with only diabetes or HIV or hypertension. Now we see patients coming with 2 or more conditions, even in our primary healthcare facilities or in the general practice. And it creates a major challenge of managing these patients. Palliative care has to be a part of it. We cannot just not talk about the palliative care when we are talking about the management of chronic conditions. It implies that we need to have a systems change. We have to include cascading. For example, we need to invest cases to mobilize funds. We need the real-time data so that we understand how are we doing in terms of the managing the patient. We need to engage, and we need to talk about the co-production of the healthcare along with the health professionals, the health managers, as well as the patients and the communities that we serve. We need to have a multi-sectoral approach, and we need to invest in research so that we understand that what we are doing. Just to talk about the data governance, that we have a established system for management for the surveillance of communicable diseases such as TB and HIV. Unfortunately, we don't have a similar system for non-communicable diseases. We learned from the HIV but there are some differences, and we need to leverage these lessons which we learned from the HIV. To decrease the non-communicable diseases risk factors, we need an all-of government and all-of society's approach, as well as the health systems reform if we have to address that. We need to understand and unpack the role of different actors. We need an action at individual, community, sub-district, district, province, and national and global level if we need to address this animal. And lastly, we need to develop healthy societies at a local, national, and global level. So what is this strategic plan is different from the previous one? The first one, there is previous plans were like hundreds of pages, and this is only like 30 pages document that which is succinct and actually talking about some of the key areas that which we wanted to draw your attention. So the vision of this plan is a long and healthy life for all through the equitable access to the prevention and control of non-communicable diseases. And we looked at the various guiding principles such as human rights, equity, universal health coverage, integration, engagement and empowerment of the people, patients and communities, and using a life course approach. There are a number of 5 goals in this plan, and there are a number of key areas that which is aligned to it. But I like to draw your attention to the goal number 3, which is ensure the people living with NCDs receive integrated people-centered approach, health services to prevent the complication and control of non-communicable disease. My colleagues, this is the way I think we can play a significant role as the medical doctors, which is our key role on this regard. These NCDs, NSP, look at the 5 voluntary targets and the 25 indicators of the Global Action Plan for the NCDs. It lays the foundation for action for all NCDs and risk factors and focusing on the care cascade, especially for the diabetes, hypertension, and followed by cholesterol, cancer, and other conditions. We inform the new multi-sectoral strategy for the tobacco control, obesity, and articulate with the existing policies and strategies such as the cancer and mental health. The main focus of the scope of this plan is that to strengthen the community level services to address the hypertension, diabetes, and mental health conditions at a national level, at a provincial level, and as well as district level. We like to create a shared priorities in our fight against the non-communicable diseases, and the 5 lessons for us from the government side is to understand and respond person needs within a context, reaffirm the common understanding of NCDs at the various stakeholders, leverage lessons from HIV, acknowledge the source of the lessons, and provide feedback. And government is accountable not only for the policy, but also to enable and sustain implementation of the plan so that ensure that we get a better health outcome. South Africa has a responsibility to report on the 2 global priorities. One is the SDG targets as well as the WHO Global Action Plan for the NCDs. And it requires the comprehensive target set for South Africa for SDG 3.4, which is talking about the reduction by 1/3 premature mortality of NCDs through prevention and treatment and promote mental health and well-being by 2030. This requires progressively to improve the wellness and reduce the premature morbidity, disability and mortality from NCDs through the continuum of care and life course which I mentioned before. We need to strive to achieve the 9 voluntary targets and 25 indicators mentioned in the Global Action Plan for the NCDs. So how are you going to implement it? There are a national strategic things that talks about that from July to September 2022, there are certain action needs to happen at a national level, at a provincial level, as well as a district level. And one of the key factors is a national level, what we thought that we should have 3 or 4 high-level indicators which actually support the cascading which I mentioned before. And the district and the provinces need to develop those indicator sets which actually assist them to develop the cascades. However, we must caution that we shouldn't overburden the healthcare system with too many indicators because it will not only provide more information, but it would be useful in planning and budgeting. So we shouldn't just add the indicator sets for governance. We should actually use this for better implementation of this plan. One of our immediate prioritization is the cascading, but it implies that 90% of the people over 18 must know whether they have a condition, whether it's the diabetes, whether it's the hypertension, whether it's the cancer, etc. 60% of those people that who knows their condition must receive their intervention if necessary, and 50% of the people receive the intervention if they're controlled. What it means that if you multiply them, it is 90 times 60 that gives you times 50. That is actually is a very small number of the people that who among the people that who have conditions will be actually managed and well controlled in that regard. So what it implies, the 90% of the people that will control the type 2 diabetes or hypertension by 2030, and 60% of them who are having the condition are well diagnosed, that means that 54% of the people, and 50% of that means 25% of the people that who have the condition that actually been well controlled. And this graph shows you that among the 100% of the people who have total diabetes, only 49%, 19% of them will be well controlled if the 90-60-50 model. So what is our role of the medical doctors for implementation of this NSP? The first thing, it is about the co-production. What it implies the delivery public services in an equal and reciprocal relationship between the professional, people using the service, their families, and their neighbors. So we should all be working together. And as a health professional, as a medical doctor, we have a significant role to play. How do we do that? We need to walk through the data governance, clinical governance, care coordination, especially the multimorbidities, and integrated care between the primary healthcare and hospital services, public and private sector, and the community organizations. And there are different role players for different health professionals and health managers who can play a significant role in that regard. I just mentioned it here that this action plan looking at national level, creating experts group at the national and provincial level, and we hope some of you will be willing to serve in this experts group to support the provinces and the national in terms of implementation of this plan. We also need to be contributing at a district and sub-district level so the plan can be properly implemented and monitored and evaluated. Just to give you some ideas of what role we can play, So when we talk about 90% of the people should know their status, that means that we need to screen everybody who come to our facilities for chronic conditions. And we then diagnose and treat those preconditions like pre-diabetic. If 60% of the people receive treatment, that means we need to initiate treatment and ensure they're adherent to the treatment. The 50% of the people receive intervention and control. That means that we need to manage the hospital admission when necessary, and effective hospital admissions will require actually address us to reduce the morbidity and mortality associated with it. We should serve in the experts group. We invite you to be joining us to manage this process through be part of the expert groups, manage the facility-based data and use the shared decision making, because we might have some geographical discrepancies among the various parts of the country, like urban or rural, or even the various parts of the districts or sub-districts, and we should be able to understand that and manage accordingly. We should respond to the patient level data so that real-time data analysis and identify the problems and strengthen the management of those conditions. And we should be responsible for the NCD management at the district level, like the district clinical specialist team. For example, a dyad of public health physicians and the PSC trained nurse can address those problems. So in conclusion, Chair, that we should actually be the part of development, implementation, and monitoring the NCD cascade of care, and can be seen as a starting point. And we, as the doctors, should play an important role in this regard. We should enhance the system that we currently have. We should use the electronic health records, require prioritization, particularly the digital health systems that which we need to address this. We need to have integrated health systems. When we are talking about the integrated health systems, we are not only talking about the public and private sector, but also between the primary healthcare and the hospital sector and the community-based approach, what we have mentioned. The NCD complex, for example, the hypertension, the obesity, we need to start with a few parameters which are well collected, start on one disease such as diabetes mellitus, which become the killer disease in the country. Thank you, and thanks a lot again for giving me the opportunities to present this document in front of you.
Thanks very much, Prof. Shalin. Do you want to say something before I don't want to monopolize the starting.
Thank you. Thank you, Prof Basu, for that innovative new approach to something that has plagued us, and that looks like a very practical way to improve the health for all. If there are any questions from the floor.
Maybe before the questions, thanks, Prof. Because I'm a clinical governance person, really this is very important to us, leaving no one behind. I think that is the way the approach that we have to promote. I really love the strategy for the NCP, the National Strategic Plan, leaving no one behind. And also the 3 C's that you talked about and the funding model. I'm happy that you at least talked about the mental health together with diabetes and hypertension, because mental health is the name of a game now, whereby the youth and also the old people, because of the challenges of life and post-COVID, we're actually seeing a lot of patients coming to hospitals with substance induced psychosis, which is really a big challenge. And then the people-centered approach, which you have actually highlighted, together with the COPC, which Dr. Shange also talked about, is the way to go in the future. The 90-60-50, I wish we can actually copy the one for the HIV, 90-90-90. But I love the 90-60-50. Maybe we must actually strive for 90-90-90. Thanks, Prof. I really appreciate it.
Debs, there's a question. Will GPs be granted access to electronic health records?
Good morning, colleagues, and good morning, Chair. It is really a pleasure to present this. Yes, we are all, as you are aware, probably 54% of the population. Around 57 million of the people actually already have been enrolled in the national health insurance. So all the people that whether we are a general practitioner, whether we work in the public sector, private sector, everybody should need to get access to this system. And I like to illustrate the point about the co-production, because it is extremely important that as medical doctors, we play the key role in terms of the implementation and co-producing the health of the people living in our country. Thank you, Chair.
Okay, thanks, Prof. I don't see any other further questions. We still have got 17 minutes. Maybe Prof can highlight some of the things that you feel we need the take-home message from this presentation.
I think from our side, I think the SAMA as a professional association of the medical doctors needs to play a key role, and we need to embrace this and own it with our Department of Health so that we can contribute significantly, because as you probably agree, and what you heard from my two previous speakers, Prof Ueckermann and Dr. Shange, both highlighted the challenge during COVID with the non-communicable diseases. And Dr. Shange's presentation about the multimorbidity highlighted the need to address the NCDs. And my plea to all my colleagues here present is to be part of this process, take ownership and address this so that we can, at the end of the 5 years, we can be proud to achieve the required targets set by the SDGs. Thank you. Over to you, Chair.
Thanks very much, Prof. And thanks to SAMA. I don't know actually penned this conference, but these are very important topics which each one of us is supposed to take forward and implement it in our community. I hope it's not going just to be a talk. Our CEO is here. I'm happy he's taking notes, and then is going to give us some way to implement all the things that have been highlighted in these conversations that we're having in this conference. This is very, very critical for all of us. Charlene?
Thank you for that. Yes, I agree. I think it's important for us as practicing healthcare professionals to embody this in all interactions with patients and with colleagues. But I think we also need to look at how we can inculcate this in our teaching of the medical students so that they too start reshaping the paradigm in which they find themselves, so that they take it forward into their clinical practice in the years to come. Thank you to our speakers. Thank you to our participants. And thank you again to SAMA for hosting this and for asking us to be part of the panel. Stay safe, everybody, and go well. If there are no further questions, over to you, Dr. Mawea.
Thanks, Charlene, for those kind words. I'm handing over to our CEO. I see he's waiting patiently with the pen and paper to go forward.
Thank you, Dr. Mawea. To Dr. Mawea and Dr. Bagwandin and all the presenters for this session, a warm world of thank yous. It's been really insightful. And I think there are a lot of lessons that, we've gleaned from the presentations. And I think, as you point out, we don't want this to be merely a talk shop, but someone will go back and look at how do we take some of these ideas that were presented in this session forward. NCDs, I think, as clearly articulated, by all the speakers, a big problem that we need to be dealing with. But more importantly is that, compared to the time when one was a young doctor, you hardly get a patient that has got only one condition, but it's likely to be multimorbidity. And I think Dr. Shange did a great job in terms of highlighting some of the challenges and some of the approaches that can be taken in making sure that we treat those patients comprehensively. Thanks, Prof, I think with the NSP, the National Strategic Plan for the NCDs, and I do agree that there needs to be an alignment in terms of the policy and what it proposes, some of the critical success factors that need to happen at the ground level, and the guidance that you gave in terms of the different stakeholders, how they contribute to the NSP, I think has been very useful. I do thank Prof Ueckermann, who has taken us through, a reflective and retrospective way, how we dealt with this pandemic when we started, when there were no particular, specialists that would be looking at this thing, what we did, what worked, what did not work. And I think all those, reflection puts us in a better position to deal, with the next pandemic that may be coming our way. So a great session. Thanks once again, Dr. Mawea and Dr. Bakwandin for sharing this. And thank you so much to Dr. Shange in absentia, Prof Basu for the presentation, and Prof Ueckermann for an interesting session. We have a bit of time, and for colleagues that are at the branch level, it's an opportunity for them to network. So I would request that we come back at 11:30, leg stretch, coffee, and if you can come back for the very last session of this conference at 11:30. Thank you very much.
How are you today, doctor? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for doctors today.
Speculation has been about exactly what the president will announce. Will we descend down to alert level 2, and with it, what are the stipulations, all of that?
Because of you,
I fear less.
I hurt less.
because of you, I'm back at work.
I'm playing with my children.
And our days can begin to feel normal again.
Because of you,
I know the true meaning of leadership,
Of courage.
Of love.
And I see what it means
to truly sacrifice.
all because of you.
To all our frontline healthcare workers,
Siyabonga.
Danke.
Enkosi. Thank you.
How are you today, Doctor? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for Doctors today. With over 750 patients being treated at any one time, we are reimagining healthcare to bring you South Africa's largest virtual hospital.
It was advisable for me to be hospitalized at home.
I was so scared to go to hospital.
I mean, the comfort of being at home, of course, is first and foremost.
At home, that work wonders.
Discovery Health Hospital at home. Connect to quality hospital-level care in the comfort of your home through cutting-edge digital healthcare technology.
This little device that they attach on my chest.
It's just brilliant. It was comfortable. It was easy.
Rest assured at home with round-the-clock remote monitoring.
I would be woken up at night because my temperature was spiking.
A clinical care team is on hand 24/7 to check your vitals in real time.
Like they would also call me on a daily basis around.
I found the experience very good, professional, the attention to detail.
With a focus on recovery, our supportive services offer medicine and food delivered conveniently to your door.
I felt like I was in very good care. They know exactly what they're basically doing.
Connect with your doctors daily via virtual ward rounds.
The platform has been extremely useful to engage with our patients.
They would always call me in the morning to find out how am I, what.
Your personalized care team is our priority to meet all your medical needs.
Even having bloods drawn, that was done from the comfort of my bed.
Because I felt like I was getting Rolls Royce treatment, and I said,
and when you need hospital-level interventions, we'll bring them to you. Healthcare professionals are on hand for home visits for your complete peace of mind.
Absolutely, first world-class care.
Connected, convenient, complete care for your hospital stay at home. Hospital at Home, Discovery Health. Reimagining healthcare. How are you today, doctor? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for doctors today.
Speculation has been about exactly what the president will announce. Will we descend down to alert level 2, and with it, what are the stipulations, all of that?
Because of you,
I fear less.
I hurt less.
because of you, I'm back at work.
I'm playing with my children.
And our days can begin to feel normal again.
Because of you,
I know the true meaning of leadership,
Of courage.
Of love.
And I see what it means
to truly sacrifice.
all because of you.
To all our frontline healthcare workers,
Siyabonga.
Danke.
Enkosi. Thank you.
How are you today, Doctor? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for Doctors today. With over 750 patients being treated at any one time, we are reimagining healthcare to bring you South Africa's largest virtual hospital.
It was advisable for me to be hospitalized at home.
I was so scared to go to hospital.
I mean, the comfort of being at home, of course, is first and foremost.
At home, but it worked wonders.
Discovery Health Hospital at home. Connect to quality hospital-level care in the comfort of your home through cutting-edge digital healthcare technology.
This little device that they attach on my chest.
It's just brilliant. It was comfortable, it was easy.
Rest assured at home with round-the-clock remote monitoring.
I would be woken up at night because my temperature was spiking.
A clinical care team is on hand 24/7 to check your vitals in real time.
Like they would also call me on a daily basis around.
I found the experience very good, professional, the attention to detail.
With a focus on recovery, our supportive services offer medicine and food delivered conveniently to your door.
I felt like I was in very good care. They know exactly what they're basically doing.
Connect with your doctors daily via virtual ward rounds.
The platform has been extremely useful to engage with our patients.
They would always call me in the morning to find out how am I, what.
Your personalized care team is our priority to meet all your medical needs.
Even having bloods drawn, that was done from the comfort of my bed.
Because I felt like I was getting Rolls-Royce treatment, and I said,
and when you need hospital-level interventions, we'll bring them to you. Healthcare professionals are on hand for home visits for your complete peace of mind.
Absolutely, first world-class care.
Connected, convenient, complete care for your hospital stay at home. Hospital at Home, Discovery Health. Reimagining healthcare. How are you today, doctor? Well? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for doctors today.
Speculation has been about exactly what the president will announce. Will we descend down to alert level 2, and with it, what are the stipulations, all of that?
Because of you.
I fear less.
I hurt less.
Because of you, I'm back at work.
I'm playing with my children.
And our days can begin to feel normal again.
Because of you,
I know the true meaning of leadership,
Of courage.
Of love.
And I see what it means
to truly sacrifice.
all because of you.
To all our frontline healthcare workers,
Siyabonga.
Dankie.
Enkosi. Thank you.
How are you today, doctor? Well? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for Doctors today. With over 750 patients being treated at any one time, we are reimagining healthcare to bring you South Africa's largest virtual hospital.
It was advisable for me to be hospitalized at home.
I was so scared to go to hospital.
I mean, the comfort of being at home, of course, is first and foremost.
At home, it worked wonders.
Discovery Health Hospital at home. Connect to quality hospital-level care in the comfort of your home through cutting-edge digital healthcare technology.
This little device that they attach on my chest.
It's just brilliant. It was comfortable, it was easy.
Rest assured at home with round-the-clock remote monitoring.
I would be woken up at night because my temperature was spiking.
A clinical care team is on hand 24/7 to check your vitals in real time.
Like they would also call me on a daily basis around.
I found the experience very good, professional, the attention to detail.
With a focus on recovery, our supportive services offer medicine and food delivered conveniently to your door.
I felt like I was in very good care. They know exactly what they're basically doing.
Connect with your doctors daily via virtual ward rounds.
The platform has been extremely useful to engage with our patients.
They would always call me in the morning to find out how am I, what.
Your personalized care team is our priority to meet all your medical needs.
Even having bloods drawn, that was done from the comfort of my bed.
Because I felt like I was getting Rolls-Royce treatment, and I said,
and when you need hospital-level interventions, we'll bring them to you. Healthcare professionals are on hand for home visits for your complete peace of mind.
Absolutely first world-class care.
Connected, convenient, complete care for your hospital stay at home. Hospital at Home, Discovery Health. Reimagining healthcare.
Welcome back. For the last session, I'm going to hand back to the CEO of the association, Dr. Basu Ntlapo.
Thank you, Renier. In the interest of time, I'd like to warmly welcome Prof Cox from the SASOM to facilitate our last session of the day, as well as the last session of the conference. And this will be looking at updates in occupational medicine and health. Prof Cox.
Thank you, Dr. Ntlapo. I'm Don Cox, the chairperson of the Society of Occupational Medicine, and I wish to thank SAMA for the invitation for this organization to participate in this new, after 2-year absence, conference and communication. I just want to emphasize for the speakers that we have to take the time to have all your Q&As as a participant or log-ons or connection. Use the Q&A. Click that we can see what you want to know after the presentations. And then I'm going to start straight away with the first speaker of the morning for SASOM is Dr. J Lapere. And he is the legal advisor of the society. Jan has a master's degree in law from the University of Port Elizabeth. Is with all his activities as the occupational medical consultant and specialist as such with SASOM also. Jan, I think that you are well known and the floor is yours. Thank you very much.
Good day, colleagues. Thank you for the opportunity from an occupational health wing to talk to the entire medical profession. It's quite a privilege for me to do this, and it's an honor for SASOM to have a whole session in the SAMA Congress. I'm going to share with you a very important aspect of occupational health, which relates to sickness in the workplace and sick absenteeism. And I'm very grateful that our undergrad colleagues are also going to listen into this, because as you will see, it's an exciting but also quite a depressing status quo on the subject we're talking about. I've got no conflict of interest, but I've got a massive interest in this field. As medical practitioners, we are extremely privileged. We can make people undress, we can make people ask the most awkward questions, as long as they're appropriate for what we're busy with, but we can enter deep into people's minds, and all those privileges we get with a background of a good ethical line of thinking, an ethical line of acting, and an ethical line of reasoning. And this particular subject that we're dealing with here, as you will see, the ethics are often where the problem lies. We're going to have to enter the sphere of employment, which is a legal sphere, and I'm going to take you shortly to what employment in South Africa really means in terms of the organization of that between an employer and employee. And then we're going to go to absence, and to paid absence, and to sick absence, and how that payment and also that certification is something that's bestowed onto medical practitioners as a sign of the massive trust that society has in us to be the persons that certify when such an instance occurs. It cannot go without rules, and there will be legal rules, and there will also be very important the ethical rules of the council for which we registered. And in our last portion, I want to go to when non-conformities happen and go through the failure modes, and also show you that not only are there lots of failure modes, which is the bad sign, but the good sign is that we've got a council that looks after those failure modes. And for instance, in 2020, if you go to the website of the HPCSA and you go click on guilty verdicts, you'll find that amongst the medical practitioners, of the 16 charges which were found guilty, 6 of them relate to sick certificate abuse, showing how, for the wrong reasons, this is an important subject. So if we go and look at how employment is regulated in South Africa, like everything, it falls under a constitutional, under our constitutional democracy, where the rights to a fair labor practice and the right to a healthy labor environment are basic rights in the Constitution, and hence must then also be embodied in statutory law, in labor law. Our South African labor organization also includes common law, and it also includes contract law. And that's quite important when you look at the aspects that we're dealing with here, when you have to be at work and you're actually not at work. The Labor Relations Act is particular on work capacity and may terminate on ill health. The basic conditions of employment is the one that really enacts the right to paid sick leave, paid family responsibility leave. The Unemployment Insurance Act also allows some form of payment of sick leave when your basic conditions have run out. The Compensation for Occupational Injuries and Diseases Act allows for temporary total disablement, which is 75% of your wages, which is also paid as a sick leave in case you have an occupational injury or you have an occupational disease. And then the Employment Equity Act, for us, regulates the right for an employer to engage in medical examinations. And then the Occupational Health and Safety or the Mine Health and Safety Act, depending on where the employer works, they define fitness for work medical examinations and medical surveillance for employees that have health exposures. So if you look at the common law duties of an employee, they include that if you got a job, you have to be at work. And so the common law and the contract law are mixed here, in that it's a contract that you must be at work. And so if you're not at work, you breach those duties. And you also, when you breach those duties, 2 things happen. Number one, your contract is essentially gone because you've broken it. And secondly, when you're not at work, whilst you're not working, you lose your income. So if it wasn't that we had a statutory superimposition of a right of an employee to be off whilst being sick, our common law would not accommodate for this. Contract law accommodates for a complicated thing called temporary supervening impossibility of performance. That would be the builder who has to finish your house by the end of the month, but has got 2 weeks of torrential rains which were unplanned in his building schedule, and which then cannot deliver you the house. Now, that in contract law, that would then be an impossibility of performance of something that he could not foresee. And so in labor law, that same principle has been adopted. So if you're sick, it's not something you planned, it's not something that you organized, it's something that came upon you, and it renders you impossible to perform the duties as an employee. Because of that principle, you're not in breach of your employment, and your employment is basically suspended for the time that you're not able to, and then the contract itself remains in force. Obviously, in contract law, there won't be any payment for this. So we need to go the next step, which is to go to the statutory right, to the basic condition of employment right, which says that every employee who, and here are a whole lot of conditions. So it's a very important principle to understand that the right to be off sick and the right to be paid when off sick are all conditions. And if you look at, for instance, employees who work less than 24 hours a month do not have the right to paid sick absence. Also, the right to paid sick absence is only for the same amount of days that you would have worked in 6 weeks. So normally if a person works 5 days a week, it would be in 6 weeks over 3 years, sorry, the same amount of days that you work in 6 weeks over 3 years. So in 6 weeks, you work 30 days. Over 3 years, you get 30 days of paid sick leave, which is like 10 days a year. People who work in hospitality and work 7 days a week can get up to 42 days of sick leave. And then you also only get the wages which you normally paid. So if you're used to a lot of overtime pay, then your sick pay is a lot less. And then unless you're off 1 day a month, 2 days per 8 weeks, if you're off more for any time more than this, you need a sick certificate. Now, what the law reads there, it reads that the employee must, on request by the employer, produce a medical certificate stating that the employee was unable to work for the duration of the employee's absence on account of sickness or injury. The law then goes further in defining where does that medical certificate come from. And so it's a medical certificate is one that's produced by the employee on the request by the employer. So most employers will have a policy that says if you're off more than 2 days in 2 months, you must produce a sick certificate. Some employers might even want one for every sick absence. They're entitled to request that. And then the certificate must state that the employee was unable to work for a duration of the employee's absence on account of sickness or injury. And then lastly, it must conform to the rules of the council which registered the practitioner. Medical practitioners can issue sick certificates quite unconditionally in terms of their registration. South African nursing practitioners can do this under Section 56(6) of the Nursing Act, so under quite specific conditions. And allied health professions council registered persons can also do this under specific conditions. And each of these councils have got their own rules, and obviously we are going to deal here with those of the HPCSA. And a very important first principle that every medical practitioner must honor is that if you're unable to work because of illness, why would that be? And if we get to the end and we see when the council is questioning why would that be, if the doctor got so far as to examine and evaluate the employee, which in many instances didn't even happen, but if that happens, then you should be able to answer the question, is the employee so sick that he cannot work? Is the employee not physically being able to attend work? His legs in plaster, he can't drive. Does he require health management which requires rest or hospitalization or being somewhere else? For instance, a cancer patient on chemotherapy who has to go in regularly. Could he be a risk to others? We've seen that now with SARS-CoV-2. Could he require quarantine or isolation? Could possibly the illness aggravate through work? Maybe we look, for instance, at the recovery after a hernia operation and somebody doing physical work. And then, of course, health management, going from one doctor to the other, being investigated, being tested, might impair work attendance. I might have missed some reasons. I left some dots there for you, but this really has to be the question asked. You book somebody off sick. That doesn't certify that the person is off sick. It certifies that the person is sick and unable to work. And so that question must always be able to be answered. If we get now to the rules of the Health Professions Council, clearly what you see, the lawmakers have got an enormous trust in us as a profession. And they trust essentially that our sick certificate has got the same value as a bank check. Because if somebody earns 4,000 Rand a month and you book that person off for 1 day, for 1 week, then that person will earn 1,000 Rand. And your sick certificate is then worth 1,000 Rand. So it cannot be that incredible right is given to practitioners without rules attached to it. And so Rule 16 of the HPCSA's rules gives a lengthy set of conditions. And this is what the sick certificate must look like. Number one, it must identify the practitioner who issues the certificate. I'm going to come to that on locums, because it could well be that you are a locum doctor at some other doctor's practice, then there would be 2 practitioners on that sick certificate. The ones whose stationery is being used, I did not put the details of what stationery is required in the HPCSA in this presentation, but when you get a copy of it, right at the end, there's a slide that shows that. And then secondly, if you're a locum doctor, your signature, initials, surname in block letters, and your HPCSA registration number must be on the certificate that you've issued. Then there are 2 dates. There's the date of the issue of the certificate, and then there's the date and the time of the examination. And that can be quite different. A 3rd date can be put on there, but is not required to be put on there, which is the date that the employee says she became ill. But sometimes that may be important when we get to the Dixit certificate. Obviously, the patient must be identified. The council even wants you to put the employment number if the employee has an employment number. And then we get to the first hard fact, the substance of the evidence. Where did you get your evidence from? Now, worldwide, ethical rules and councils allow 2 types of sick certificates. The one is the one that emanates from personal observation. So that would be saying that I have examined you and I certify you to be unfit for work. And the second one would be the Dixit certificate, where the information that you put on the sick certificate does not come from your personal examination observations, but it comes from, and very importantly, it comes from information from the patient, but which is based on acceptable medical grounds. So it cannot be, I went to the cricket and I need a sick certificate. It has to be on acceptable medical grounds. And that's a sick certificate where essentially say, I was informed that the employee was unfit or is unfit for work. So we're at the substance of evidence. We now need to also the reasons for absence. Now the council says that the doctor must put a description of the illness, the disorder, or the malady in layman's terms if consented by the patient. At the South African Society of Occupational Medicine and in my personal consulting capacity, this is an endless fight with practitioners who read this the other way around. It's not the doctor who decides whether the diagnosis must be on there. The diagnosis must be on there if the employee consents to this. And this can be very important to the employee. Safety critical employees will not be allowed to be back at work unless the employer finds out what was wrong and what could be the impact of that on the safety or on the health in the workplace. So in many instances, the reason why the diagnosis must be there relates to the health and safety in the workplace. But if the patient is not prepared to give such a consent, both in terms of the Basic Condition of Employment Act, the right to sick pay is triggered by the right to the sick pay is triggered by mentioning that the employee can't work, and the ethical rule is followed if the employee, if the doctor writes that, to my opinion, and based on an examination, the patient is unfit to work. So that's the reason for absence, remembering that the diagnosis must be there unless the patient objects. Then the council requires that you also define whether this is a total indisposition or whether this is a partial indisposition, and the employee could still do a portion of the duty, less strenuous duty. It's very good that in here you actually describe what you feel, either what the employee cannot do or what you feel the employee can still do. Just putting their light duties doesn't help the employee. Because after all, we as medical practitioners, we do this for our employees. We do this for the betterment of the employee's health, and that's his total health. That may be the health related to the condition that he's busy with, but it can also be related to his psychosocial health, his security of income, his stature at the workplace, his credit at the workplace. Then there must be an exact period of recommended sick leave. Many practitioners have pre-printed sick certificates that say, I saw him on the 5th and he's fit to work on the 15th. Well, it actually never says that the employee is unfit for work. It never gives an exact period of recommended sick leave, which is an essential part. If pre-printed stationery is used, then a practitioner must delete the words. usually those words allow the difference between a Dixit certificate and a true certification. And it's important that that is mentioned. There are a lot of employers who quite rightfully will not allow a Dixit certificate. There are queries, there are questions, there are all kinds of issues which may be raised with a SIG certificate. And for that reason, the last part of Rule 16 of the Health Professions Council clearly states that where an employee comes back after a SIG certificate and the employee directly requests the practitioner for a short, brief factual report on exactly the things that we're talking about here now, is what was the anamnestic complaint, what was the clinical finding, what were the tests, what was the diagnosis, what was the impact on the fitness for work, and why did you book that person off. Such a short factual report must be written by the practitioner if the patient requests this. Not if the employer requests it, if the patient requests it. So once again, for the betterment of the employer, this must happen. Specifically on revealing the diagnosis on a medical certificate, and specifically on getting that consent, there's a separate rule in the Health Professions Council's rules, which says that to ensure this, that all this is in place, the doctor must give enough information on which the employee should base his or her decision on allowing the diagnosis to be put on the certificate. You have to put to the patient the reason for the disclosure and to what, in your mind, the likely consequences of the disclosures are. If that patient suffers from diabetes and has come for the very first time with diabetes, I think it's a very important fact that the occupational health service at the employer should know this and can assist with it. So in many instances, there's a benefit, a direct benefit to the employee. And then also, obviously, an explanation as to what will be disclosed and to whom it will be given. But in most SIG certificates, the SIG certificate is given to the employee, who then passes it on to the employer. So that would not directly impair on a SIG certificate. So it's writing a check with a SIG certificate, and it's really easy. You've seen the 10 rules. They are not complicated. They make a lot of sense if you look at the power of the SIG certificate, and they give a lot of trust to our community to actually trust us doctors in doing this. And then it goes wrong. And so the first one is that it's nearly impossible to get 5 legible SIG certificates in a row. For some reason, doctors have got their own alphabet, and these certificates are illegible. Now, for those of you that are old enough to remember a check, if the bank couldn't read what's on the check, the bank is not going to give you the check. And an employer in their right mind does not have to pay for a SIG certificate, which is not legible. So if you look at doing this for the well-being, for the benefit, for the betterment of your patient, you have to make sure that it's a legible SIG certificate. The second one is, if you think it's a good idea to write something, if you think it's a funny idea to write something, then it's usually a bad idea. It has to be the truth. The truth is very important. Untruthful SIG certificates are very common. The most common error in SIG certificates is that they don't fulfill those 10 rules. The stationery is printed wrong. The way it's defined is not correct, and it doesn't give the required information. The second biggest one is that they're illegible, and the third biggest one is that they're not honest. The doctor on the right, that SIG certificate actually comes from the internet, but I still took the doctor's name out. But she wrote, "As I've been informed by him, he has a terrible headache. On examination, he's highly intoxicated with alcohol. He always comes to see me on a Monday and wants the day off." it's very honest, but it doesn't really assist the patient. There is a cry for help, but maybe the cry for help should be given in another way. We have these certificates of people that are booked off from Monday to Friday for a cold. I don't know where any of those 7 reasons come in there. Or these weird and wonderful diseases that only general practitioners diagnose inside 6 certificates: fibromyalgia, dorsalgia, fibrositis. And then there are other 6 certificates where you have these phenomenal, formidable conditions which book a person off on Monday. I have personally seen one with amoebic dysentery, which is a notifiable condition, that was booked off on a Monday. But you have people with both fibrositis, influenza, and pneumonia that on Tuesday are better, or hepatitis, or pyelonephritis, or all those conditions. So there has to be a nexus between what you could possibly have done to find out the diagnosis, between the truthfulness of the diagnosis, and between the length of the time that the person is off. And so this honesty is a problem. It brings us really in bad light. And here's an extract from a high court judgment in Mthatha, where a doctor, this judgment is also freely available on the internet, but I did remove the doctor's name, where a doctor issued a 6 certificate so as to make that one of these gang members was not there. And so the judge wrote this about us. Now, after all the things I've said, how important it is that we as individuals, but also we as a collective, stay up. It says here, Dr. N was a poor witness. He does not remember what time he saw the patient, for how long he examined the patient, what treatment he gave the patient, or where he handed the medical certificate to the patient. The most disturbing fact is that the doctor signed a certificate. If the doctor sees nothing wrong issuing a certificate with this blatant falsehood, how could he not have issued a certificate with a false date on it? How can you trust the doctor that actually does this? It appears from his evidence that he had neither examined nor treated the patient for specifically backache, and that he granted the medical certificate simply on what the patient had told him. He then booked him off for a day. He also gave him no medication. So the court then ordered that the doctor would be subjected to the Medical Dental Professions Board, and this doctor was eventually punished by the board. Locum rules. If you employ a locum, then that locum works for you and works under your guidance and under your authority and under your accountability. And so in the 22 HPCSA judgments, if you employ an unregistered person or a person whose registration is not up to it as a locum, then that is an unlawful act. And then you can go to that website and you can find out that the things I mentioned in today's short talk, all of them have been subject to an assessment by the Health Prevention Council and have been subject to punishment of doctors, even failing to delete the words which are not applicable, mostly when dates are being fiddled with, but also when certificates are given for people who weren't even seen at all. So the HPCSA is adamant in that. And so in conclusion, a medical certificate must enjoy the full and indisputable notion of truth. It's a legal document, it's confirmed, and it's confirming facts, and it must be limited to those facts. It must be based on your own questioning and examination. It must be produced by the practitioner who establishes the fact in person. It must be completely truthful. It must be guaranteed by your conscientiousness and your faithfulness. It may be certified with your signature, and your identification must be next to that signature. And I've added the superfluous fact that it must be a legible communication for the benefit of your patient. I thank you.
Thank you, Dr. Lapere. To illustrate again that a legal document is a letter of recommendation and can be accepted yes or no by somebody. We have to carry on, and remember to write your Q&A questions in the box. And at the panel discussion at the end, we will take time to answer them all. I'm going straight through to the next speaker. That will be Dr. Heidi Williams. She is the EXCO member of SASOM, specialist, occupational medicine specialist, and linked to the University of Cape Town as an honorary associate lecturer. She has quite experienced in her publications and scientific field. Dr. Williams, the floor is yours.
Good morning. Thank you for inviting me to speak today. I'd like to talk about medical surveillance. We'll talk both about the current practice as well as the recent updates. So we'll go through the background to medical surveillance, the context as well as definitions, the medical surveillance program, what to do if you have an abnormal result, and then what is new. So mostly spirometry changes, but we'll also speak about the mental well-being. And then finally, we'll wrap up. So this is an extract from the Employment Equity Act. Medical testing of an employee is prohibited unless legislation permits or requires the testing, or it is just justifiable in the light of medical facts, employment conditions, social policy, the fair distribution of employee benefits, or the inherent requirements of the job. So inherent requirements of the job is something that you'll hear later in this discussion. So what legislation requires testing? I'm just referring to the Occupational Health and Safety Act. The Mine Health and Safety Act also requires testing. So under the Occupational Health and Safety Act, there are a few regulations that do explicitly require testing, including the construction regulations, driven machinery regulations, also requires testing. So under the Occupational Health and Safety Act, there are a few regulations that do explicitly require testing, including the construction regulations, driven machinery regulations, hazardous chemical agents, etc. We also require testing under the National Road Traffic Act. We've all done PRTPs, as well as the Hazardous Substances Act, which is the people who are exposed to radioactive materials. With the inherent requirements of the job, these are minimum medical standards of fitness, which refer to the capability of the employee to perform the tasks required, which is to the required standard or without undue risk to him or herself or others, and the ability to function within the working conditions associated with the job. But that is without potential to be exposed to certain, certain hazards, without undue risk to his or her health. So I like to have definitions so that we know exactly what we're talking about when I use the word medical surveillance. So medical surveillance is a widely used tool in occupational health to assist in preventing employee ill health and injury. There are various definitions, and I provide two here. The one is from the US CDC and the other is from the UK HSE. But all have similar risk-driven themes. It's risk-driven, as I've mentioned. They're ongoing, they're systematic, collection of health data with early diagnosis of work-related disease, and it must be related to preventative action. So it provides a feedback loop to the risk assessment. The terms medical surveillance and medical screening have sometimes been used interchangeably and inconsistently in the past, and it's important to understand distinctions between these two activities. Medical surveillance describes activities that target health events or a change in a biologic function of an exposed person or persons. A surveillance program involves recurrent longitudinal examinations and data analysis over time, so it looks at change over time. Medical screening is a complementary activity, sometimes considered one form of medical surveillance, that is designed to detect early signs of work-related illness by administering tests to apparently healthy persons in a cross-sectional approach. So the one is longitudinal and the other is cross-sectional. Screening activities generally have a more clinical focus when compared to medical surveillance. So with screening, the screened person may be directly treated in response to the screening test. But medical screening data collected in a standardized manner, aggregated and evaluated over time, can also be evaluated as a part of surveillance program. So I'd like to show you some examples of trending that we do. This gentleman that we have over here is let me try and highlight him. This gentleman over here is a pipe fitter in the maintenance department. The nature of the job is that they are exposed to very loud, intermittent noise. If you can imagine a machining workshop. He started the company with features of noise-induced hearing loss on audiogram and is worsening. As you can see, there's a 5.4% drop in his percentage loss of hearing as baseline as compared to now. So apart from a buy quiet procurement program, which the company has initiated, and as well as training on the hearing conservation program, the only other intervention to slow the progression is better hearing protective devices, because he's a pipe fitter. The nature of his job is noisy. He was fitted with custom hearing protection devices, and we will continue monitoring his hearing. I've got another example, and in this example, the person is a chemical operator, is an operator in a chemical plant. He has had a 16% shift from baseline in the last 4 years as in his lung functions, which is significant. In occupational medicine, with routine annual or 2 yearly spirometry in a generally healthy population, 15% over and above age-related loss is significant. So as you can see, he's had a 16% loss of hearing. Odor loss in his lung function tests. He would require further investigation, which I will discuss later in the talk. So let's talk briefly about a medical surveillance program. So as I've mentioned earlier, the program is risk assessment driven. Both the occupational hygiene program, which is measurement of exposures, and the medical surveillance program is guided by the findings of the health risk assessment. So the health risk assessment, as we've said before, informs test selection, it informs the minimum standards, and it gives us indication of what the potential exclusions and restrictions would be. So this is an example of where the health risk assessment reveals that there is a potential exposure to aniline. So aniline is an organic compound, the simplest aromatic amine. Its main use is in the manufacture of precursors to polyurethane, dyes, and other industrial chemicals. Like most volatile amines, it has the odor of rotten fish, quite unpleasant. So the health effects of aniline, of exposure, if you are exposed to aniline, aniline is irritating to the skin, eyes, and the respiratory tract. An effect can result from all routes of exposure, so it is skin absorbed. It induces methemoglobinemia, which impairs the delivery of oxygen to tissues. It may also cause destruction of red blood cells, which manifests acute or delayed hemolytic anemia. Heart, liver, and kidney effects may be secondary to the hemolysis. Insufficient delivery of oxygen and destruction of red blood cells may cause cardiopulmonary complaints with the development of ischemia, arrhythmia, and shock. With acute exposure, many of the adverse health effects of aniline are due in part to the formation of methemoglobinemia. Aniline converts the iron +2 in hemoglobin to iron +3, which impairs its oxygen transport capacity. So as I mentioned, the health risk assessment informs test selection, minimum standards, and medical exclusions restrictions. So the HRA indicated that there is a risk of exposure to aniline. So the operators who are going to work in that area, the tests we would do is obviously history and examination with a focus on previous cyanosis and cardiovascular exam, full blood count at baseline and periodically, and the biological exposure index, because aniline has a biological exposure index. It's listed in the hazardous chemical agents regulations. So one can measure actual absorption of aniline. And these BEIs are total P-aminophenol in urine or methemoglobin in blood. The minimum standards depends on the requirements of the job. So sometimes the job would say you need to be able to lift heavily, or you need people doing night shifts and so on. So the minimum standards would depend on those requirements. And the potential exclusions restrictions would be employees with a particular vulnerability. For example, thalassemia, G6PD deficiency, other hematological diseases, or impaired cardiovascular status. So that's just an example of how the health risk assessment can inform the medical surveillance program. So we'll discuss what we do if there's an abnormal outcome. So the abnormal result may be unrelated to the work. And if it is so, you refer to the primary caregiver. It may be related to work. And if it is it caused by work, or does it impact on the ability to do work? If it's potentially caused by work, there needs to be further investigations. If it impacts the ability to do work, one has to decide if it's unacceptably increases vulnerability. And if so, we would need to have workplace restrictions. Or does it mean that the person is unable to perform their job? And that means that there would be an incapacity process with accommodation. So is there another job for this person to do that does not make them increasingly vulnerable? So let's discuss this. So the same chemical operator we mentioned earlier with the lung function changes example, he was noted to have a drop in his FEV1, 16% drop, as I said. He reports experiencing an occasional tight chest for 6 months. He has been working at the facility for 4 years. So the first question is this condition work-related? Well, this is a chemical facility. He wasn't directly working with sensitizers, but there are agents like irritants that is in the facility. So it may be work-related, so we need to investigate further. So the next question is it caused by work? And then he was working, as I said, in a facility that does not make sensitizers, but it does have irritants. On questioning, he reports, though, that he only has coughing when he exercises, and that's when he gets a tight chest. He's got no other triggers, no workplace association, not in any way. So his only trigger is when he runs, after he runs for about 10 minutes, he starts coughing and he gets a tight chest. So does this diagnosis impact on his ability to do his work? At present, it does not. He only gets a tight chest when he coughs, and he does not meet the criteria for asthma because his response to bronchodilator wasn't sufficient. But he has been referred to his GP, and he will be monitored closely. And there may be restrictions from working with known sensitizers in the future. So we're now going to discuss what is new in the world of medical surveillance. So what has been quite significant is that there's been an update. The American Thoracic Society standardized their spirometry guideline, and that was released in 2019. And following on that, the South African Society of Occupational Medicine issued an updated guideline document, the spirometry in the workplace. Both these documents look at the quality and how spirometry is actually performed. So the key updates, the contraindications to doing spirometry was updated. That is, the forced expiratory maneuver using spirometry increases intrathoracic, intra-abdominal, and intracranial pressure. So of course, caution must be used for people with medical conditions that could be adversely affected by this increasing pressure. So contraindication include those due to increase in myocardial demand or changes in blood pressure, due to increase in intracranial, intraocular pressure, due to sinus and middle ear pressure, intrathoracic and intra-abdominal pressure, and infection control issues. The device QA procedures were updated. The minimum quality assurance requirements are maintenance of a log of calibration results, documentation of repairs, recording dates of software and hardware updates, recording dates equipment is changed or relocated, and then calibration verification must be repeated after any such changes before further testing begins. Operator training and maintenance of competency has been addressed, and a list of activities to avoid before testing has been updated. Vaping was, for example, was added as an activity to avoid before doing testing. Acceptability and repeatability criteria have been updated, and a new grading system for quality was developed. The grading system ranges from A, which meets all acceptability and repeatability criteria, to E, acceptable, but not repeatable, and includes U, which is usable, and F, not usable or acceptable. So those were the main updates regarding how spirometry is performed and the quality of the spirogram. The other big update is that the ERS published an updated standard in their July issue last month. So this really is hot off the presses. There are many updates relevant to occupational medicine practice as well as medical surveillance. So this table is from the article and compares the 2005 statement to the new standard. So the reference equations, what is recommended now is to use the GLI reference spirometry, reference equations for spirometry, which is a different reference population group. They have re-emphasized the use of the lower limit normal 5th percentile in defining the normal range. The bronchodilator response and what is significant bronchodilator response has been updated and changed quite significantly. I'm going to talk through that. The interpretation of change over time within occupational medicine, as I've mentioned earlier, 15% plus age-related is still seen as a good way to identify significant change over time. But in other adults, the FEV1Q ratio, the details are in the article, is used. And this FEV1Q ratio needs to stay quite constant. If it drops, the change in FEV1 is significant. And the severity of lung function impairment and how that is categorized has also been changed. They're now using Z scores or Z scores, which is mild, moderate, or severe, depending on the Z score. But I'm going to discuss Z scores and responsive testing a bit further. So all three updated guidelines endorse the use of the lower limit of normal as 1.64 standard deviations below the mean, and that is the Z score. So the Z score shows the number of standard deviations a result is from the mean. So if we have our mean in the middle of our bell-shaped curve, the Z score shows the number of standard deviations away from that mean. So 90% of the population would have the Z scores between 1.64, which is over there, and minus 1.64 to plus 1.64 spot there. So this would be 90% of the population. At the 5th percentile, corresponding to a Z score of minus 1.64, there's a 5% chance that the results in a healthy individual be at or below this level. The 5th percentile represents a trade-off between incorrectly classifying a low value in a healthy individual and missing a clinically significant reduction in lung volume. The lower limit of normal is not a cutoff between healthy and disease. So it is just that at that point, the person may have a problem, not that the person does have a problem. So the question would be, why move away from percent predicted? Because those are quite easy. Because percent predicted does not take into account the observed age-related changes in measurement variability. So these rule of thumb only approximate lower limit of normal in the mid-range of age, leading to systematically missed interpretation of results, particularly for women, children, and older adults. For example, the lower limit of normal for FEV1 varies from 81% predicted at age 10 years to 68% predicted at the age of 85. So using 80% as a cutoff would grossly overdiagnose or overdiagnose somebody who's older. So the new statement also talks to bronchodilator responsiveness testing. It recommends that changes in FEV1 and FEC following bronchodilator testing should be expressed as the percent change relative to the individual's predicted value. A change of more than 10% of the predicted value indicates a positive response. So these are actual numbers from our gentleman, the operator that we discussed earlier with a drop in FEV1. So with the old or the previous method, you would have had 280 moles change in FEV1 improvement and 10% change. Remember at that before we said 200 mole and 12% change in FEV1 is considered significant. So he didn't quite meet the criteria, though the 280 mil was a big increase in FEV1 volume. With the new method, you'd have your post-bronchodilator value, subtract your pre-bronchodilator value from that, times it by 100 and divide by the predicted value. So in this example, these are actual numbers. We had 3.06 liters minus 2.78 liters times 100 divided by our predicted FEV1, which was 3.93, and he had 7% change. So the gentleman does not have significant responsiveness using either method. So those are the changes in spirometry, especially the interpretation changes are quite significant in occupational medicine because we use lung function testing quite a lot, and that would be a significant change within occupational medicine practice. I'm going to change tack a little bit and talk on mental health. So I have to confess that this fits into screening more than surveillance, but it would be remiss not to mention mental well-being and mental health, as the pandemic has had such a huge impact on mental health. So worsening mental health, psychological distress, burnout, and substance use have been accelerated substantially by the pandemic. Workers experienced increased stress due to changes in their work organization and environment. And stress has also included exposure to the virus itself, and people worried about getting sick themselves, their family getting sick, dying, hospitalization, changes in work arrangements and schedules, increased workload and job demands, and effects on work-life balance. So from an occupational health focus, we attempt to identify distress before it spirals into burnout. And remember, I mentioned earlier that we want to have early diagnosis of disease in order to assist employees with healthy coping mechanisms and improved resilience, and refer appropriately if need be. And occupational health practitioners are also uniquely placed to assist employers to institute practices that enable communication, increase social interaction and collaboration for work teams, and to guide employers to respect work-life boundaries, as all are important for alleviating stress and isolation. So I think, we've heard a lot about the mental impact of the pandemic, and it's important for us not to forget it. And as occupational health, we need to have a renewed focus on assessing mental well-being within the workplace. So to wrap up, medical surveillance is risk assessment driven and provides a feedback loop to the risk assessment. So we have the health risk assessment, as I mentioned, which identifies whether medical surveillance is needed. If the surveillance is needed, we establish a medical surveillance program, which, as we said, it means that there's the test selection, minimum standards, exclusions or restrictions are identified. We manage the performance of program and collect the data. I showed you some examples of data that's been collected. The data is analyzed and then act on results, which feeds back into the health risk assessment. So if one identifies, for example, in our aniline exposure, that there has been exposure to aniline through our biological exposure index that is unacceptable, or it's too high, or it's above the limit, then it feeds back to the health risk assessment, say there's a problem here, we're having unacceptable exposure to aniline. Thank you very much for your attention. We'll be available for the Q&A a little bit later.
Dr. Williams, thank you very much that you have emphasized that the doctor has to do a diagnosis even when there's a medical surveillance or a medical screening process going, and the difference between it. It's really appreciated. I'm going over to the next speaker, as said, Q&A at the end of the session. The next speaker will be Dr. Ntatamala. He's also an occupational medicine specialist, lecturer at the University of Cape Town, and a SASM EXCO member. Dr. Ntatamala, the floor is yours, please.
Thank you so much for the kind introduction. So as described, I'm Dr. Ntatamala, and I will be speaking about evaluating workability and managing disability. It is often a problematic area for many of us, and I'm hoping to provide a pragmatic approach that one can use, which, when one is in their practice. So in terms of the outline, we will just do a very brief introduction. I will have a squiz over the definitions, impairment, disability, incapacity, so that we understand what we're speaking around, and of course speak very briefly about applicable legislation, talk about assessment of impairment and the various ways one can do it, and of course spend a bit more time on an approach to disability assessment. And I'll be using the feeder framework, which is a course on the fundamentals of impairment and disability assessment, which I'll speak about later, of course, and then use a case to illustrate some of the points that are being made. If we've got some time, we'll talk briefly about the challenges in impairment assessment and capacity management. So as I've mentioned, that as medical practitioners in our various disciplines, in our various roles as interns, as medical officers or specialists, we are often called upon to assist in medical assessment of impairment and or disability by patients. And this often is after acquiring an injury or a disease, and somebody comes through and wants to be either medically boarded or really request a letter of recommendation for accommodated duties. It is quite well known as well across the world that accommodating people with disabilities in the workplace does improve self-sufficiency, it does improve self-esteem, and of course is associated with improved physical and mental well-being, including of course improved financial well-being or financial stability as well. If one looks at South Africa's current social security system, one can think about it in three forms or three pillars. The one is, of course, social assistance that is non-contributory and largely is administered by the government, so disability grants, old pension grants. There's also social insurance, which is contributory as well and is mandated by law, and this would include the infamous compensation fund, the road accident fund that many of you might have worked with as well, and the unemployment insurance fund, or the UIF. And of course, there are many voluntary or supplementary arrangements that can be made, and you may be familiar with these group life schemes and the likes. When looking at the concept of functioning or disability and its interrelation with health, I often find it very helpful to go and look at the definition offered by the International Classification of Functioning, Disability and Health. Think of it as the ICD-10 coding of disability and health. And effectively, what this WHO framework says is that in measuring health and disability, it is important for one to not only consider the health condition or the disorder, but how it interrelates with the various components of the individual as well. So how does the health condition interact with the environmental factors, the personal factors as well, and how does it impact on the performance of the activities of daily living, activities of work, and participation in society? An example would be this: Mary, who is 60 years old, diagnosed with osteoporosis. In terms of bodily function or structures, it is known she's got vertebral fracture at T12 and a low bone mass density at the hip and spine. However, if one looks at the activities that she commonly engages in, exercising, walking, and how these can be impacted by the osteoporosis, one can have a better understanding of how disabling the osteoporosis can. And of course, it is important to not only look at the health condition, but look at personal factors that may be important in her case, such as a family history, or fears of fracturing, and of course, environmental factors as well, which might include the kind of work that she does. If we delve deeper into the definitions, so very broadly, impairment, or think of impairment as loss of function. And we think of disability as or rather we look at the impact of the loss of function on the ability of the individual to work, to socialize, etc. And I'll give a few other definitions as well. So impairment is an alteration of normal functioning capacity due to disease or injury, and we use different medical means in order to determine the impairment. And of course, it is after, or rather the impairment is assessed after a diagnosis has been established. And I'll speak a lot about establishing a diagnosis and of course ensuring that one is on optimal treatment. This is one example, and some of you may have attended the AMA guides training. So this is the American Medical Association. It's got guidelines on evaluating permanent impairment. And this is a consensus-derived percentage where estimates of loss of activity, and this would reflect the severity, or rather the scores that are obtained reflect the severity of the impairment for a given health condition. And of course speaks to the degree of associated limitations in terms of activities of daily living. And a typical example, chapter 15, would look at the upper extremities, and as you can see, if there is an amputation of all the digits, one would represent it as 100% hand impairment, but if there are specific anatomical areas within the hand that have been affected, there would be different percentages that are attributed. So when we look a bit deeper at the definition of disability, so as I've said, this is an alteration of the capability to meet one's personal, social, or occupational demands. The AMA guidelines, for example, define it as an alteration of an individual's capacity to meet personal, social, and occupational demands because of an impairment. Okay, and the British Social Security law brings in the concept of total or partial inability to perform one's bodily or mental processes as well. And a similar definition is undertaken or is ascribed to by the South African insurance contractors. In terms of incapacity, the incapacity or the definition can be easily thought as one's ability to fulfill the inherent requirements of the job. And this could, of course, be on account of ill health, but it could also be on account of poor performance. As medical personnel, we do not enter into the realm of discussing poor performance because that is the domain of human resources or people management. But where we commonly come in our different roles is in dealing with the role of incapacity as it relates to ill health. So there are different laws or different legislation whereby disability benefits are prescribed or discussed, and these would include the Social Assistance Act, which regulates the assessment and payment of disability grants, and I'm sure many of you have been approached, particularly in the public sector, by individuals requesting for disability forms to be completed. The other forms, the other forms of statutes or legislation include the Labour Relations Act, which provides for fair labour practices and provides guidance on incapacity due to ill health or injury. The Employment Equity Act promotes employment equity and eliminates unfair discriminations against people with disabilities. And of course, this is another question that will come through to you, individuals who are requesting to remain within employment. And this is where the Employment Equity Act, in particular, its Code of Good Practice, comes into effect. Another legislation would include the Basic Conditions of Employment Act, which speaks to sick leave provisions, the UIF Act, the Compensation for Occupational Diseases Act, OIDA, and the Road Accident Fund as well. Just very briefly about the Employment Equity Act. It does have various provisions within it, but it is important for me to just highlight the code of practice on the employment of people with disabilities. And the definition of disability in the Employment Equity Act is quite interesting as well. So it defines disability as a long-term, so it is a condition that exceeds a period of 12 months, recurring or permanent physical, mental, intellectual, or sensory impairment that affects a person in relation to their work performance. Okay, and of course it does cover the employer's obligations to all individuals with disabilities, and the concept of a reasonable accommodation comes in as well. In terms of the Labour Relations Act, it has a code of good practice on dismissal, and of course it draws a distinction between temporary and permanent medical incapacity, and also does cover the employer's duties to ensure fair dismissal on account of medical incapacity. And of course, many of us would be drawn into that process where a medical report is sought by the employee or the employer in the process of a fair dismissal being considered. Just to briefly speak about the distinction between temporary and permanent incapacity. So permanent and temporary incapacity can also further be divided into total or partial incapacity, and you may find these terms being used particularly within the insurance industry. So an example of temporary yet total disablement would include, for example, somebody suffering from influenza. They are sick for a total of 10 days, and they're totally, of course, away from work. Temporary partial disability would, for example, be an individual who is an engineer or accountant who has suffered a low limb fracture, but is still able to function at 50% capacity at home. And of course, permanent partial disability would include somebody who's been diagnosed with fibromyalgia, for example, but however is still able to work. So work can be adjusted to 50% capacity. And permanent total disablement might be somebody with degenerative disease who is unable to perform all their functions at work. So in terms of assessing medical impairment, what is required? So of course, it is required that one has good clinical practice, and I will not belabor the point, good history-taking examination and the appropriate special investigations, and of course referrals as needed. And there are multiple clinical guidelines that inform how one can assess impairment, and this would include the insurance industry guidelines. The South African Society of Occupational Medicine has got guidelines. COIDA circular instructions do speak of how to assess impairment for work-related conditions. The AMA impairment guidelines, if I've mentioned, are but a few. And of course, there are also a host of ratings tools that could be used for hand function. For example, the MODEPS, the DASH rating tool can be used for psychiatric conditions. The GAF score, for example, could be used, vision, Snellens, etc. Right? So there's a host of impairment rating tools that could be used as well. As I've said, an example from the AMA guidelines is this. So table 5 speaks about the criteria for rating permanent and impairment due to asthma, and as you can see, there are concepts such as whole person impairment, and this could move from class 1 between 2 to 10% to class 4, where the impairment or whole body impairment is 45 to 65%. If one is to look at locally things in terms of the assessment of impairment for occupational asthma, there are circular instructions, and this is one example, circular 176 from COIDA, which speaks to how one would assess impairment due to occupational asthma. So there will be a table 1 and table 2, and all of those combined would result in table 3, which is a summary impairment score. And as you can see there, there are different, depending on one's score, one is then able to assess disablement from 15% to a fatal case of occupational asthma, which would constitute 100% of impairment. And here I just give an example of the Association of Savings and Investments of South Africa, and here they've got guidelines on the management of impairment on grounds of mental illness or mental ill health, and they've got very great flow diagrams on how one can actually assess for impairment on psychiatric grounds. Okay, so Just moving on to speaking about, so we're now moving away from the assessment of medical impairment to really assessing incapacity or workability. So the ability of somebody to meet the inherent requirements of their job. And of course, in this case, it's really important to have consent. Right, I've seen many times patients or workers coming through are sent by employers, but they are not even clear as to why one is coming there. So one has to ensure that you get consent and that the individual understands that they are now entering into a process where they will be where one will be assessing their incapacity or their workability. Okay? There should be a formal process of referral. There should be a formal process within the policies of an organization that one follows or one requests if you are asked to do an assessment. And of course, it should be very clear as to what the role of the doctor will be. Of course, for those of us within the occupational health space, it is important to remember the issues around geo-loyalty, where one may be insourced within a company and one has to, of course, do the very best for their patient, however, also cognizant of some of the pressures that would come from the actual employer or the service provider as well. And this would also go for those who are called in for independent medical assessments by employers. It is important to adhere to ethical principles and, of course, to allow for adequate time for case management. If there is a need, call a friend. So there is a need for independent assessment, let that be. And of course, to adhere to best practice guidelines and to, of course, adhere to labor law, which I touched on early on. And of course, for many of the pension funds, it is important to ensure that there is enough time for you to submit your recommendations or your findings as well. And of course, very importantly, though there has been traditionally a move to medical boarding or ill health retirement, it is also important to understand that we should be focusing on a return to work and how we facilitate return to work. So in looking at the framework for medical assessment of disability across, and this is of course a framework that can be used across all social security system benefits, it is important, as I've indicated right at the beginning, to understand functioning and its interrelatedness to disability. Right? So at the center of the core is, of course, an assessment for work disability or incapacity, but it is important to, again, remember that there is the health component or the health impairment, and there are various elements that could be contributing to it, the person's age, comorbidities, genetics, etc. But there are also personal factors such as motivation, attitudes, and etc., which would need to be considered, and also the environment, as I've said, right? So social support, the legal framework that one is operating in, one's occupation as well would need to be considered. Okay. This is the disability framework that I propose. It provides a very good background on how to approach disability assessment. And right at the beginning, of course, is ensuring that the diagnoses and prognoses is done adequately. Then you move on to ensuring that maximal medical improvement has been achieved. And of course, once this has been achieved, it is important to do the impairment assessment using the required or the relevant assessment tools, as I've spoken about. It is also important to consider whether or not there is a need for a functional capacity evaluation by an occupational therapist. And finally, once one has got all this information, it is important to assess whether or not there is a need for a return to work program and vocational rehab. And I will, of course, will speak to each of these individually. While all of this is happening, right at the top, of course, is the need for somebody to be involved in the case management, and of course, for all of these practices to be happening within the ambit of the legislation and within the ambit of the ethical principles, as you can see on the side of the diagram as well. And of course, at the end, we do also need a decision to be made regarding the work disability as well. So in terms of making the diagnoses and prognoses, I will not belabor the point, but it is important to make the correct diagnoses, as incorrect diagnoses do lead to flawed assessment processes as well. The medical diagnosis, of course, does define the medical condition and does guide how medical decisions around treatment and prognoses are done as well. It is also important to ensure that one determines the prognosis, and of course, this is predicting whether the clinical condition will improve. Do we expect it to improve? Do we expect it to deteriorate over the next few months? Because that, of course, will impact on the decision that is ultimately made, of course. Or do we expect that it will remain stable and that the person might perhaps likely recover? And in the step, of course, is ensuring that one has allowed the patient to receive optimal treatment and rehabilitation as well. The second step, as I said, is ensuring that one has reached maximal medical improvement. And MMI, as we commonly refer to it, is really the point of recovery where the clinical condition is stable. So we do not expect that there is any further surgical or medical intervention that would lead to significant changes in the next 12 months. Okay? And MMI is very well described in the AMA guidelines, for example. Once MMI has been determined, it is also important to then say, well, let us now assess your level of impairment. Okay, and of course, this involves the assessment of the medical condition and translating it into the findings into a percentage score, as I showed with the impairment scoring of the upper limb. Okay. Once you have adequately assessed the level of impairment, it is also then important to ask yourself whether or not the person is capable of performing their work activities, right? So the functionality of the individual is really the domain not of the medical practitioner, but it is the domain of the occupational therapist. So the occupational therapist will consider the person's body functions and structures, the environment, personal factors and their health status, and will really go into the workplace or into the home and observe how capable the individual is able to perform their daily activities or their work activities within the context of their own of their own impairment as well. Okay. Step 5, once a functional capacity evaluation has been done, and of course there are many different kinds of functional capacity evaluations. Some would be looking at mental functioning, some could be looking at physical functioning as well, in the case of a manual laborer, for example. So a return to work program would also need to then be considered, and this of course is a planned process to facilitate the return to productivity and to manage the impact of the disability in the workplace. Okay, so again, as you can see, I've not spoken about ill health retirement or medical boarding at this point in time, because the key is to determine the level of disablement and then understand how one can organize or facilitate a return to productivity for the individuals, right? And this would of course include perhaps finding alternative placement, finding alternative ways in which to do the tasks like they normally would, and of course finding reasonable accommodation within the workplace. And an effective return to work program will allow affected individuals to integrate into the workplace environment at the same or alternative position as well. And of course, I must underline that this accommodation or reintegration would have to be reasonably practicable as well. In terms of vocational rehabilitation, it is not only good enough to identify what activities could be altered or what activities could be or what alternative accommodation could be provided. It is also important that a multi-professional team is involved to ensure that the individual's participation into the work environment is optimized, right? So this would normally again be done by occupational therapists in conjunction with the line managers, looking at the different settings, the different activities that the individual within the workplace is able to do, right? And of course, within the context of the individual's health-related impairments or limitations or restrictions. Okay, and as we conclude, it is also important to then, of course, have a very good case manager. And the purpose of a case manager is to facilitate all these processes. As you can see, there are some processes that the medical practitioner will be involved in. There will be some processes which HR will be involved in, and there will be some processes which occupational therapists are brought in. Right? So it is important to have a central base where the case management will be done, and commonly it is through the human resources practitioners or an appointed individual within that directorate or area. Okay, and the collaborative process really takes into account what is required to ensure that the individual's health, their social care, educational needs, and employment needs are actually attended to. And as I said, all of these steps will happen in within the context of legislation and legislation and good ethical practice as well, good ethical principles. And finally, of course, after jumping all these different hoops, it is important at the end to make a decision regarding the disability. And of course, this would, as I said, consider the interaction between the health condition, the activity limitation, the participation restrictions within the workplace, and the interaction between the external environment and the personal contextual factors as well. Okay. Now, as an example, and this is a real-life example of one of the patients that I saw, and the picture is from the internet, it is not the patient. Mrs. XA is a 53-year-old general assistant or cleaner at a busy hospital, and she fell about a year before I saw her while on duty and injured her back. She subsequently suffered from severe low back pain with a need for analgesia and frequent rest breaks both at work and within the home. A referral to orthopedics revealed that she had degenerative changes, L4, L5, and a herniated disc. Laminectomy and spinal fusion was thereafter performed, and this of course was covered by the compensation fund. She was optimally managed in terms of pain management. She received rehabilitation, and the surgeon was optimistic that the back function would improve. However, due to the nature of the work, there were reservations that perhaps she would benefit from being medically boarded. And however, in discussions with her, she was clear that she is still young, and she would still relatively young, and she wants to continue working and supporting her family as well. However, does admit that the work environment does aggravate her symptoms. Now, looking at the processes that we've discussed, the diagnosis and prognosis has been discussed, and now the issue around whether the maximum medical improvement has been reached was the next question. She was referred back to the orthopedic team, and the team believed that she had reached MMI, that no further improvement was expected or deterioration was expected within the 12 months. And using the AMA guidelines, she received 1% whole person impairment score. And this, of course, was done by us within the occupational medicine team, but oftenly, once you as practitioners have made the decision, the assessment might be made by the SASA doctor, or it might be made by the insurance doctors on the other side. Okay. An FCE, functional capacity evaluation, was requested, and the occupational therapist came on site, observed that she was involved in frequent bending, twisting, and lifting to clean floors, the bathrooms, etc. for much of the day. And this affected trunk rotation and lumbar spine stability as well. So the occupational therapist, looking at her functional capacity, recommended that she could continue working with appropriately accommodated duties or tasks. Okay, and of course recommended that the work environment allows for a return to work program and vocational rehabilitation as well. And this included limiting how much she would be able to lift to 2 to 3 kgs, reducing the bending, so working mostly at desk or arm length, and of course being able to take frequent rest breaks as well. And she was in collaboration with HR, we were able to relocate her to a less busier section of the hospital, so the more administrative section as well. And the case management was taken on by the hospital HR, and there is an incapacity management committee which deals with issues of disability and incapacity within the hospital setting as well. And I would actually advise that it is important for one to ask whether or not there are such committees in dealing with your patients as well. And this involved communicating and collaborating with the key stakeholders, the orthopedics team, the HR team, the occupational health team, the occupational therapy team as well, and of course monitoring regularly her return to work, and scheduled appointments within the occupational health team were booked, and she was to be reviewed every 3 months, and of course could call in during the time in between the appointments as well, should there be problems experienced within the workplace. So a decision regarding her disability in the context of work, though initially the orthopedic team had recommended total and permanent disablement, the case does serve to highlight that where individuals are motivated with personal factors, and where the environment, particularly the work environment, allows for reasonable accommodation, it does lend itself to individuals being able to reintegrate into the workplace and to be able to function optimally within the workplace, supported of course by the various stakeholders as well. So all of these factors enabled an outcome that resulted in a successful return to work. So this is of course one instance where everything went well. However, we do know that the processes are marred with challenges, and from a medical point of view, there's commonly lack of concordance between symptoms and the signs that an individual presents with. There is of course a high burden of psychiatric impairment as well, issues around the perceived injustice from the employer, and how does one deal with these as well. Issues around does one really know when maximal medical improvement is reached, and whether the individual has been compliant. And of course, they are, though I've showed you a few tools, they are often imprecise and based on ongoing research that has been happening as well. And of course, a very key problem that is faced is the poor communication between healthcare professionals as well, particularly within our state or public sector resources as well, and the lack of a multidisciplinary team focus in ensuring that our patients return successfully within the workplace. From an employer's point of view, they are commonly poor management of ill health and capacity by employers, lack of consistency in its application of these policies, where certain individuals get all the accommodation in the world and some individuals are effectively pushed to retire early or to be medically boarded. There is also often delayed intervention in management and a lack of return to work programs or consistent programs within the workplaces, particularly for small, medium enterprises and the formal economy as well. And from a personal or individual patient point of view, there are also issues around the individual either requiring or requesting to return to work early, or even requesting for prolonged time away from work. And what we do know for certain is that the longer individuals are away from work, the less likely they are to return back. So it is thought that 50% return to work after 6 months of leave, and only 10% of individuals return to work after 2 years. And finally, there are also challenges, of course, in terms of the insurers and social security agencies, lack of clarity on the benefits, lack of an uneven response, and of course, rigid criteria for impairment and disability, which may not at times be made obvious to the treating medical doctors, medical team as well. And of course, it is often very cumbersome and an expensive process of appeals and rejection, and of course very long forms that require quite a bit of time as well. Okay. In terms of COIDA and compensation fund and its challenges, as I said, many of you probably know that it is quite slow. There's lots of inefficiencies in the systems, and of course there's really a lack of focus on rehabilitation and the return to work processes that I've been speaking to and advocating as well. So in conclusion, it is important for all of us to really focus our energies on ensuring that we assess medical impairment very well, that our diagnoses, our prognoses, our special investigations are done appropriately to inform the assessment of a disability that subsequently occurs. Okay. It is also important for us to recognize that we are not the sole arbiters on declaring permanent disablement, that it is a team effort. It does require a multidisciplinary team, even in conditions which are quite dire and with poor prognostic factors. It is important to involve the entire team as well. Objective findings are, of course, of greater value in impairment assessment than subjective findings. And it is also important to really, when one is outside of their depth, to refer as required. And of course, doing all of this, recognizing that there are certain ethical and legal requirements that should be adhered to as well. So as I've mentioned, the fundamentals of impairment and disability assessment course. This is a free online course offered by the insurance CETA, and it was developed by various experts within the industry as well. And I've just left in the slides the link should you be interested in doing this online free course as well. And acknowledgements to the team, Professor Shahida Adams from the University of Cape Town and Dr. Blanche Andrews from who's currently in Ireland, but previously worked in the insurance industry. Thank you very much.
Thank you, Dr. Ntatamala. With due to time constraints, I think Dr. Mawea, the chairperson, hand is up. You want to come in? Unmute yourself. Dr. Mawea? No. Then I'm going to the next speaker, the last speaker of this session is Dr. Tesema, a community internship doctor that has experience from the Knovel Hospital in rural Limpopo, Steve Biko academic, and he's going to talk about his stress and internal community problems with experience. Over to you, Dr. Tesema.
Hi, I'm Dyspnea Is Common, a community service doctor currently employed at WF Noble Hospital in rural Limpopo. It's an honor to be here today and to give a talk on the topic, which is mental health of medical interns and community service doctors. Today, I'm going to be talking about sick people, but not the people that we deal with day to day, but the people that are right by our sides. The healthcare workforce have been at the forefront of the COVID-19 response in South Africa, providing and sustaining an essential service. Yet the mental health of healthcare providers tends to be overlooked and is not prioritized. The rate of suicide and depression amongst doctors is known to be greater than the general population. However, mental health is not yet recognized as a public health concern, and the mental health of doctors is disregarded by the Department of Health. Adding more adversity to an already overburdened healthcare system was the COVID-19 pandemic, which revealed and exacerbated the mental health struggles of medical doctors and brought to light the poor and challenging working conditions in which medical practitioners are subjected to work in. The existence of mental health is often not acknowledged amongst medical doctors. unless it's in their own patients. Medical doctors have poor insight into their own symptoms and find it difficult to admit to weakness and to play the role of a patient. This could be due to many reasons, but I believe one of the main reasons for this is because the medical field in general advocates for perfection, and perfection is often rewarded. As a result, doctors are constantly trying to prove themselves in a very competitive field and are constantly trying to outperform and outwork each other. Often admitting to mental health problems appears to be seen as weakness, and there is a stigma that it may affect your career progression. Not being able to recognize or admit poor mental health in the early stages leads to poor coping strategies. Often problems are identified when it's way too late and have long-lasting effects on doctors and their families, and ultimately the quality of care that the health practitioner can offer to their own patients. Depression, anxiety, PTSD, burnout, alcohol and drug dependence. These are some of the symptoms of this sickness that I was describing, that we have all experienced at some part of our career. Some of us have made it out stronger, whilst many have not, and are constantly struggling with these symptoms day to day. Medical interns in South Africa are freshly qualified medical graduates that have undergone 6 years of studies at a qualifying university. They have to undergo 2 years of compulsory training, known as internship, before registering as independent practitioners with the Health Professional Council of South Africa. From there, they're eligible to complete their community service year, and from there, they are no longer junior doctors. These doctors are often vulnerable due to this being their first exposure into an environment without any established support system in place. My journey as a medical intern started in Steve Biko Academic Hospital in the year 2020, when the COVID pandemic began. My experience of internship was quite rough, and I cycled through various mental states. My interest in the mental health of fellow interns came from my personal struggles during internship, and it was definitely exacerbated by COVID. Seeing a lot of my friends dropping out of their respective internship programs, and even losing a good friend who was a fellow intern due to suicide. So I decided to do a survey amongst my internship group to better understand the mental health of others in the same situation as I. This survey was planned against the backdrop of the COVID pandemic in 2021. The objectives of my survey was to study and to explore the mental health states of medical interns. The survey was an informal survey that was conducted anonymously at the hospital, at Steve Biko Hospital, amongst the first and second year medical interns using a Google form that was distributed through a shared WhatsApp group that was shared amongst the staff members. The survey consisted of a combination of multiple choice questions and an open-ended question that asked participants how the COVID pandemic affected their mental health. The results were quite interesting. Out of the total medical interns that were employed at the hospital, which were 95 interns, 53 interns completed the survey. 39.2% reported poor to terrible mental health. 19.6% reported having average mental health. And a staggering and only 15.7% reported having good mental health. That is quite alarming. Another very interesting stat was one of the questions in the survey asked how many, one of the survey questions was, have you been diagnosed with any mental health problem since starting your internship? And a staggering 25% of interns reported being diagnosed with a mental health problem since the beginning of the internship. This was quite a shocking fact, and also brings to light the working environment that COVID and the general working environment that interns are subjected to. Another part of the survey was an open question which asked interns to give a statement as to how the COVID pandemic affected the internship. And these were some of the interesting responses out of the 56 responses that I just summarized. And some of them was stressed out and stretched too thin, worried about exposing loved ones, emotionally and physically exhausted, not getting enough emotional support, struggling with parenting, unable to manage and maintain meaningful relationships, poor working relationships with nursing staff, urgent need for debriefing spaces. One of the most common response out of the whole survey was an urgent need for debriefing spaces, which was quite interesting. The results of the survey highlighted the environment that medical interns train in as newly qualified doctors play a significant role in shaping their mental health and their ability to navigate through this career field as they transition into their community service years. An important finding was, regardless of mental health status, interns felt that it would be beneficial for there to be more psychological support from the institution where they work. Other issues that were cited in the survey was poor working conditions, lack of PPE, and poor working relationships between nursing staff and senior doctors was a great contributor to poor mental health. Long working hours was also cited as one of the things that was contributing to poor mental health amongst medical interns. Given that medical interns and ComServs are just starting out in their careers, I think it's very important to address some of these issues that was raised in the survey to improve and safeguard the mental health of interns for the benefit of both the healthcare workforce and the patients alike, as the junior doctors are the future doctors of South Africa. The conclusion to my talk, mental health problems are definitely prevalent amongst healthcare workers, and COVID only worsened it and brought to light what was already there. Their involvement as frontline workers during the pandemic, working in an overburdened and understaffed system with increased risks of infection and possibility of transmission to their own family members, and deaths of colleagues and relatives has perpetuated the poor mental health that have already been in the healthcare profession and has worsened the issue. There's an urgent need to support junior doctors, as these are our future doctors. In terms of suggestions, I'd suggest a formal countrywide survey to gauge the mental health of junior doctors and to intervene where necessary. Other suggestions to solve the problem would be debriefing spaces to be prioritized at all institutions, and even making them compulsory for all medical interns to attend a certain amount of debriefing sessions. Other things which could aid in the situation would be to improve working hours, ensure adequate staff, facilitating relationships between nurses, registrars, senior doctors, and medical interns, and create a peaceful environment that is contributing to a good mental health, and to develop a screening tool to assess employees' mental health on a regular basis. In the same way that COVID screening was prioritized, I believe that mental health screening should also be prioritized in every institution, even if it's done in a monthly basis, just to catch out poor mental health issues at an early stage, and necessary support can then be offered and tailored towards each person from there. I thank you for your time, and that's the end of my presentation. Thank you.
Thank you,
Can I
Dr.
comment?
Tesema, for your presentation. Dr. Mawea, floor is yours.
Yes. I would like to thank the presenter for what he gave to us. As the elderly, I see our chairperson is here. Chair, the elderly is here, and we have listened to the young ones. Mental health for the junior doctors is very critical. That was what he was actually saying. And then the other thing was, he said to us, we are the debriefing sessions that we need to actually, the debriefing sessions, it must be promoted, especially for the junior doctors. He talked about COVID, the environmental support, which we're not giving. He needs us to actually promote that. They always have what we call a suicidal ideations. We must actually promote that. That's me. Chair, I see you. Let's go forward. Let this be not a talk show. Let's help these young people.
I'm going over to the Q&A board now, and the first question is for Dr. J Lapere. What happens if riots and violent demonstrations impede your attendance for work as the road you use is full of rocks and burning tires with demonstrators threatening to your safety? Dr. Lapere?
Thank you. Thank you for the question. It makes no difference what is that supervening impossibility of performance in contract law and in employment law. If something happens like what you describe now is this unrest and you can't be at work, that's not something that planned. Evidently, if you're joining the protest, then you would be planning there, and that's not a supervening impossibility. There are many other supervening impossibilities of performance, and sometimes it's for us to make a call. The law also looks, for instance, at a lot of things like adoption. It looks like family responsibility leave. Some of them are paid, some of them are not paid. It looks at pregnancy. So there are other incidents where a person cannot appear at work. But for instance, on the unrest side, it would not be the sick certificate that would cover there, Professor Cox.
Right, the next question is for Dr. Ntatamala. Sorry, Ntatamala. Disability on patients with long-term COVID syndrome. Can you give comments there, Dr. Ntatamala? I see you type it, but verbally, please.
Thanks, Prof Cox. I was about to send it on the type, but effectively what I was saying is that it is, as the colleague has highlighted, an increasing problem that we are seeing. However, I would still advise and advocate that the processes that have been discussed are followed. It's quite a complex and quite a complex and convoluted problem, particularly because there is so much that we still don't know about it. But the methods or the approaches that I found very helpful is, firstly, of course, to try and ascertain, particularly for the individual. So not every long COVID patient will classically meet the definition of an incapacity, but it is important for it to be individualized, for one to characterize what exactly is the individual complaining of or struggling with. Shortness of breath has been one big problem. Fatigue has been another big problem that we're seeing, and to of course involve the other stakeholders as well in terms of trying to get the the individual to an optimal state as possible. At Groote Schuur Hospital, for example, we've got a long COVID clinic working with the pulmonologists, working with physiotherapists and occupational therapists, and the team, once an assessment has been made, also assists in giving, of course, with the assistance of the occupational health practitioners as well, giving a structured program that enables the individual to return to work. So in a hospital setting, we've had instances where individuals have a very graded return to work approaches. So if it's, if one is able to be accommodated away from a very busy clinic for a couple of weeks as one reintegrates into the workplace, so that's one of the activities that we undertake. And of course, with a very regular review as well as to how the person improves over time. So certainly it is becoming a problem that we are seeing, and as much as it's challenging, it has helped, I think, with the experiences that we've had of having a multidisciplinary team looking and tackling the problem.
Right. Then the third question or remark is, very good and much needed study. Interns need to be protected, and special programs should be in place to help them to cope with the internship and working as ComServe. There are programs in big hospitals, there are big psychology departments. Thank you for making your voice heard. Dr. Tesema, any comments, remarks?
Hello, can you hear me?
Yeah, we can hear you, thanks.
Yeah, it's a pleasure to be on this platform today. I'd like to say thank you to Sama. Thank you for the comments. I feel, what was the question? If you don't mind repeating, please. I can't hear me. Hello?
The next question maybe also, so through all the interventions are possible to do and interns need to be paid in time.
It's for you.
Hello, sorry, technical issues.
I see Dr. Aframenko has just said it's a remark, not a question. So the last one is, then our interns need to be paid in time.
Yes.
Hi, yes, thank you for the remark. If the question of interns being paid in time, I think that's important. And obviously that is a contributor to mental health. I mean, not being paid in time contributes to poor mental health in the sense that one has to make alternate plans and make plans and even go into debt, you know?
Right, that was the last Q&A.
I'm sorry, Prof. Sorry, Prof. There's a hand up from the Summer Free State branch. I think they would like to ask a question.
Right, unmute yourselves.
Good afternoon, Prof. From the Summer Free State branch, we have a question directed to Dr. Lapere. And the question is, if you consult with a patient on Wednesday, but claims that he or she has been sick since the Monday, must you book the patient off from Monday or from Wednesday on the sick certificate?
Thank you. It's a very, very pertinent question, very, very often an issue. I think the most important part is to establish what the medical facts were. Already, for instance, if that person would be off on Monday and Tuesday, and that person hasn't been off in the last 60 days, then there's no need for a cover to get paid for those 2 days, although you want to cover those 2 days. But your assessment on Wednesday has to include what you think is related to your medical findings for Monday and Tuesday. So if, for instance, the patient comes and says she had gastroenteritis, and you can see on Wednesday this patient is rattled for yourself, then you can honestly say that that person, to your opinion, was off on Monday and Tuesday. But it has to be quite clear that you saw the patient on Wednesday, and your opinion is that she could be off on Monday and Tuesday, as she communicated this to you, and maybe you then further book her off on Wednesday and Thursday. So your certificate just has to be an open communication in which those feasibilities are put in. If you're going to book the person straight off from Monday to Thursday and indicate that you've seen the person on Wednesday, that sick certificate will get rejected. So it has to be quite clear which part of it is Dixit and which part of it is your personal opinion. Free State.
Thank you, Dr. Lapere. Thanks.
That is the last written Q&A. I don't see any hands on the attendees, but none on the panelists. So I think we are more or less concluding on the session. So I'm just going to give a short summary. J Lapere indicated quite clearly that the legal document is a recommendation and need acceptance, but the medical practitioner has to do it. Dr. Williams make a quite distinct difference between the medical surveillance versus medical screening, and that's again a general physician's imperative to make the diagnosis. Then we have Dr. Ntatamala for ability versus disability within a legal framework. So the doctor still has to do the normal medical diagnosis. And then Dr. Tesema has illustrated it again. A doctor is a healthcare worker and an employer needs to see that the doctor is an employee. And it's the role of the unit manager and the HOD, not the CEO of the hospital, who is getting this definition of an employee. Therefore, I want to thank all the participants, all my colleagues that has participated. Dr. Mslapo, thank you for Sama, for inviting Sasom to attend. We really appreciate it and enjoy it. And then therefore I can say my role is now ended. Thank you.
Thank you, Prof. Let me thank you once again for an insightful and educative session. It is probably a lesson that we take from this, that interacting with the different associations, but having topics that are wide-ranging will probably be a feature of our conferences going forward. So to Prof Cox, Dr. Lapere, Williams, Ntatamala, and Dr. Tesema, many thanks for your input in this session. I wanted to just respond to the question that was raised by Dr. Maweya. Let me point out again that Dr. Maweya is our previous president in the association. So we do take those words on board, Dr. Maweya. But what I'd like to highlight at this point is that as of last year, we launched an Intern 101. We're planning to extend that to the comm service doctors. And judging from the presentation that Dr. Tesema has made, probably going forward, would like to maybe reach out to him so that we have a contribution from the first-hand experience. But what you've raised is an important issue that is taking place in the healthcare facilities, which was certainly complicated by COVID. But the suggestions made, we take them to heart. So in terms of our own contribution, with the summer intern 101 and extending to ComServe 101, we will be highlighting that as a particular issue that needs to be taken into cognizance by the administrators at the hospital level. Thanks once again. What now remains for me is to thank the team that I worked with, but to invite back on stage Dr. Mzukwa, our chairperson of the association, to give some closing remarks to this summer 2022 conference. We look forward to seeing you again. Dr. Mzukwa.
Thank you very much, the CEO, Dr. Ventilatory, for those remarks. And good afternoon to all the colleagues. I join you here today at the close of the Summer Conference 2022, which I'm sure you all agree has been more than insightful and very important. We gathered here to discuss a range of issues relating to medicine in a post-COVID environment, and we have heard from many experts. We have heard, for instance, of the effects of the virus, the role of research in defining our response, of the diagnostic challenges we face, of the health systems in South Africa, and how to build better for the future, and of strategies going forward. All of this information must shape our response. That's clear, but it must do more than that. We have had these past 3 days that we must have been inspired, and I'm sure awaken within us a desire to do better. We are medical professionals, we are doctors, and we must always work towards being better for the sake of our patients. In fact, it's not that we want to do these things. We are obliged to do it if we want to provide the best of those we care for. I also want to take you back to something that our current president, Professor Chauke, said last weekend. He said that we must not only listen and learn in the prepared sessions, but we must also do that when we are on breaks. And I want to encourage you, to urge you to continue interacting and engaging even when we have left today. It's through sharing experience and learning from each other that we ultimately improve ourselves as doctors. And I'm grateful that we could spend time together in this forum and just do that. After all, that's what a conference such as this is intended for. I want to thank all the staff members of SAMA for putting again together such an important and useful conference, and for working tirelessly to ensure everything ran smoothly. I want to thank SAMA CEO, Dr. Ventilatory, for his introduction, and Professor Chauke for his inaugural speech. I also want to thank every speaker who took time out of their busy schedules to join us and to share their knowledge with us. Your time and inputs are appreciated and valued. But most of all, I want to thank every delegate who attended and participated in this year's event. Without you, this conference would be meaningless. These are tough times. Everyone has different priorities in their lives. We understand that, but your attendance at this conference is important because it means you are invested in the future of your patients. And that really should be the guiding light for anyone in this room. Thank you once again to everyone involved in putting this event together, and for everyone who either contributed or attended. We wish to see you in the next year's conference of the South African Medical Association. I want to thank you all and enjoy your great weekend. Over to you, Dr. Ntlapo. Dr. Ntlapo.
Thank you, Dr. Mzukwa. I will not speak after you have spoken. Colleagues, thank you very much for having been part of this important occasion in the life of SAMA and our profession. Goodbye.